Evening, sir.
Hi, good evening. How are you guys?
Good evening, sir.
Good evening, everybody. How are you guys? Everything okay?
Yes, sir.
Good, sir.
Good to see everybody.
Good evening, sir.
Hi, good evening. Still got a couple of minutes. So wait. So everybody today participate in this discussion. Try to volunteer, okay, so that we can get more and more people. It'll become more interactive. Hi, good evening. Who's there?
Good evening, sir.
Yeah, switch off the YouTube. Somebody's YouTube is it's my YouTube which is on. Hang on. Just 1 minute. Let me just switch off the YouTube. Okay, YouTube. That's what was causing the sound in the background. Everybody can see my screen? Not yet. Let me share the screen.
Not yet.
Not it, sir.
Can you see my screen?
Yes, sir.
Yes, sir.
Yeah.
All right. And can you hear me properly?
Yes, sir.
Yes, sir.
Good. So today's session is going to be really easy, completely dependent on what you guys do. It's your performance, not mine. So the pressure is not on me. So it completely depends on what you guys do. If you do really well, it will go really fast. If you do really slowly, it will go really slow. So the ball is in your court for this session. Okay. And I want most people to participate. Okay. So I may not remember names when the lesson is started, but I want you guys to volunteer. So initially, everybody switch off your microphones, and then when you want to volunteer, or if you hear your name being spoken out, then just switch on your microphone and come in, and we will start. We'll get you to talk. Okay. The other thing is, everybody happy for this to be recorded or not happy for this to be recorded? Feedbacks quickly.
Yes, sir. Yes, sir.
Yes, sir.
Please record it, sir.
Record it, sir.
Please record
Are
it,
you
sir.
sure? It's going to be for eternity.
Record it, sir.
Yes, sir. Yes, sir.
Yes.
Okay, all right. I am happy with that. Okay, all right. So let us start recording on this computer. And of course, if it does, excuse me, if the session doesn't, excuse me, if the session doesn't go well, then we won't share the recording.
Yes, sir.
Excuse me. Sorry. Okay. So yesterday we did a lot of stuff, and I hope that some of you got a chance to see the recording again. And if you didn't, I hope some of you printed out that thing that I sent to you. And we will today start with revising it. We'll just go through each step one by one, and then we'll talk about various pathologies. Okay, so before we talk about pathologies, I think it's worth revising once about what we learned yesterday. Okay, so is Bhushan in the room?
Yes, sir.
Okay, Bhushan, you will start off. Okay, so but first, before I start off on the revision, there are some questions sent to me specifically by some people. So before I start today's topic, let me answer those questions. These were specifically sent by different people, so I'm trying to answer. So one question I think Ramaswamy asked me was, what is 4D CT scan? So 4D CT scan is a type of CT scan which involves not just the location, which means you're not only trying to see a x-axis, y-axis, and z-axis of the tumor, but you're also trying to see the movement with respiration or with any movement. So whenever you put in a dimension of movement into this film, then it is called as 4D CT scan. And the fourth dimension is movement, because when you're trying to give radiotherapy or you're trying to do RF ablation, it is absolutely important to know where is the tumor when your beam reaches the site where you think the tumor is, because with the respiration, the tumor will move. Okay. So this is very useful. The 4D CT scan is a new technology which is very useful for therapy, particularly when you're doing radiotherapy and RF ablations. The 4D CT scan actually gives you value by telling you that in inspiration, the tumor is 1 centimeter below, in expiration, the tumor is 1 centimeter above. So it's a very good technology, which actually takes into account the body's breathing, the tumor movement, and more importantly, also the movement of the nearby body organs. Switch off your phone. Who's that? Admin, who's admin? Whoever is admin, switch off your iPhone.
Switch off your iPhone. Who is admin?
Yeah. Okay. Thank you. All right. So this is the concept of 4D CT scan. So it takes into account the body's breathing. It takes into account the movement of the tumor and also the movement of the nearby organs. And this adds value, particularly when you're doing radiotherapy, because the radiotherapy, then you can localize into that area and reduce the side effects into the surrounding tissue. Okay. So this is a straightforward answer for, I think Ramaswamy asked me this question. It's a very good question. It's a new technology and it's worth knowing. In fact, nowadays, if you look at movies and things like that, they have got already 5D, 7D and things like that, whereas 5D and 7D involves movement of the viewer. So it's not just what you're seeing on the screen, but even you are moving or water splashes on your face. So that's another dimension to the imaging. But of course, we don't need that in medical technology. But in Hollywood and in movies, they've already got 5D, 7D, 9D. Okay, various effects they add in. So they actually make the experience better. That's what it is. That's why it's called as 4D CT scan. The second question, I think Arif asked me, Arif Sheikh, I think from Calcutta, RGCAR. He asked me, sir, could you please explain what is ECG gating for cardiac MRIs? It's a very easy concept to understand. The heart is a beating organ. MRI takes a very long time to acquire images. Okay, so you have to go through the whole of systole, whole of diastole, whole of systole, whole of diastole. So it's a very large time factor for acquiring the image. And in addition to that, there is movement. So movement also changes with every heartbeat. The movement of the heart changes. So particularly when you're trying to look at certain pathologies, maybe something like a systolic anterior movement of the mitral valve, or if you're looking at diastolic dysfunction of the heart, then you really need to concentrate on that phase of the cardiac cycle. All right. So what you do is you do ECG gating. So you target the ECG to that phase. So depending on if you want to look at systole, you target the ECG according to the systole. So only at systoles the whole acquisition occurs. And then the first, initially it will acquire everything, but during systole it will focus and give you a more concentrated image. So it's really motion imaging with specific points of a cardiac cycle. It's a very, very nice technology, particularly when you're looking at specific diseases of the heart, and it works very well in an MRI scenario. So that's what it is. You could do either RR interval or you could do P2P interval. It depends on what you want, at what phase of the movement of the heart that you want to capture in high definition. You use that phase. So you can narrow the band, you can increase the band depending on what you want. Okay. So it's a very easy philosophy, just because if you want to see diastolic dystrophy, diastolic dysfunction of the heart, you want to focus more on the diastole. So you move your ECG gating to that point on the ECG where diastole starts and systole, diastole starts, systole ends, and then you finish the gating at where diastole ends and systole starts. So you can get a more detailed analysis of the heart in that phase. Okay. Does that make sense? Does it answer the two questions that you asked? Arif?
Yes, sir. Yes, sir. Thanks.
Did you understand it? It's quite a simple philosophy, actually. It's a nice concept and it works very well because of motion that you have to gate the ECG. Okay. So you don't acquire a huge amount of data. You specifically look into that. So it's a bit on the CT side. The same example is when you're looking at mediastinal windows. So you move your gating to the mediastinal side of the things. Or if you're looking at lung window, you gate to the lung side of things. Or if you're looking at bone window, you gate to the bone window. So ECG gating is a dynamic technology which allows you to gate to a particular part of the cardiac cycle so that you can pick up pathologies and anomalies in that area. Okay, so let's start today's session. And I want to start the session first just by revising. So before I do normal, let me just tell you that whenever you see a pathology on the CT scan, okay, you have to just describe it in quite straightforward manner. There is nothing complicated about the pathology. No, in the exam is all about simple, straightforward cases. Usually we will have one pathology. Sometimes you have more than one pathology. But if you have one pathology, you have to look at associated features with that pathology. For example, if you've got lung cancer in the right upper lobe, you have to look at the lymph nodes in the mediastinum. You understand that? So you have to understand the correlation of the pathology, and you have to understand where to look. And the important thing, of course, is that you have to describe the pathology. Anything that you see, whether it's a nodule, it's a mass, it's a cyst, the description remains the same. Okay, and you have to start with site. Where is the location of that pathology? What is the size of the pathology? Now, obviously, looking at a CT, you cannot tell me exactly what is the size till you measure it. But you can always, in the discussion, say it looks about 2 centimeters, you know, which is all right. I'm not going to hold it against you if you say, if it turns out to be 2.2 centimeters. But at least in the first description, whenever we see a pathology, we say, yeah, this is about 2 centimeter tumor present in the right upper lobe. It is circular in shape. So you have to talk about the shape. You have to talk about the surface, what it looks like. You have to talk about the margins. You have to talk about the opacification, whether it's hypodense, hyperdense, or isodense. And you have to look for some signs which are specific to that pathology. But if you don't know the signs, it's okay. So anybody, to be honest, anybody can describe any CT scan. It's as simple as that. Anybody can describe any CT scan. All you have to do is go through this pathway. Location, size, shape, surface, margins, opacifications. And then you look at consistency, okay? Talk about contrast enhancement, if it is a contrast film. Talk about calcification within that pathology, if you see some calcification. Talk about the content, anything specific that you're seeing within the cyst. Are you seeing daughter cyst within the cyst, or are you seeing something floating within the cyst, or are you seeing fluid within the cyst? Talk about the surrounding structures. So what is the effect of the cyst on the surrounding structures? Okay. Simple things like there is compression of the lung parenchyma, or there is erosion of the bone, or the trachea is obstructed, or the esophagus is getting compressed. Simple things, nothing complicated, just simple things. Talk what is the effect the structure is having on the surrounding structures. And most importantly, at the end, talk about other normal structures. Either you can say everything else is normal, or you talk a little bit about important normal structures. So when you're talking about lung cancer and you've described a nodule in the lung cancer, make a statement, there is no obvious lymphadenopathy seen in the mediastinum on the mediastinal window, okay? And then last but not the least, try to reach a differential diagnosis rather than a diagnosis. I would be happier if you reach a differential diagnosis, because then you can discuss more things with the examiner. If you reach one particular diagnosis, of course you can. If it's so obvious and everything is okay, then you can reach a diagnosis. But I would always say, I'd keep this in the back of my mind. My most likely diagnosis is so-and-so, but I'll always keep this in the back of my mind. Okay, so just quickly, I'll go through these few points again. So let's look at it. Site, which is the location, the size, the shape, the surface, the margins, the opacification, any signs which are specific to the lesion. You can talk about consistency, you can talk about contrast enhancement, you can talk about calcification, you can talk about content, you can talk about surrounding structure, and you can talk about other normal structures. Now, you do not need to go through all of this. You may have all of this, or you may have some of this, but at least some should figure in your description. Do you understand that? So really, a CT scan is more than 90% of the times, it's an icebreaker. When you go into the Vivas and I put up a CT scan, I put it up to give you an opportunity to talk. And this is the best investigation to get in the exam. And don't worry about diagnosis. Don't worry whether you could diagnose or not diagnose. As long as you describe the pathology well to me, I'm quite happy. And then we can have an adult discussion, because FRCS is an adult exam. Because today you pass the FRCS, next day you're supposed to be a qualified, completely independent consultant in the UK. So FRCS at that level, we actually have a very adult discussion with people. We don't You don't have to tell me very little minor bits and bobs. You just have to have a standard pattern of description of, when I say a nodule, I mean a pathology, okay? And everything in the chest can be described using this. And if you manage to go through 10 or 12 of these points, which I enumerated, you've already done 2 minutes or 2.5 minutes. Okay, and by the time I'm waiting to ask you the next question, doctor, what are you going to do next? What is the next investigations in this? Okay, so please try to understand that CT scan is the easiest of all the investigations that you will get in the exam. Okay, and then don't forget to ask for previous scans. It's very important at the end of this thing. Say, I would like to see the previous scans, because you want to talk about growth rate. You do want to know if that whatever that pathology has it changed in size or not changed in size. Okay, so these are very standard, nothing complicated, very straightforward stuff. So become friends with CT scan. Okay, think that CT scan is your best buddy in the examination. It is there to help you to move to the next stage of the discussion. It is not there to fail you. I promise you, I have never met anybody whom I have failed on a CT scan. Never, ever. So just remember, CT scans are your best friend in the exam. Okay. The other thing that you have to remember is, this is not just about exams, okay? This is about life, about your clinical practice. Whenever you see a chest x-ray or you see a CT scan like this, okay? Whenever you see a chest x-ray or a CT scan, who is putting lines on my surface? Don't fiddle around, guys. Because we are in a meeting and not a webinar, you have control of my screen as well. So every time you try to move things around, I get a mark on this surface. So don't fiddle with your mouse and things like that. Okay. All right. So what I was saying was, every time you in life, when you start seeing patients and seeing chest x-rays and seeing CT scans from now onwards, okay, because now you've learned how to be friends with a chest x-ray, you've learned how to be friends with a CT scan. From now onwards, whenever you see a CT scan, I want you to imagine how is that tumor in real life. Okay, I want you in your brain to create a 3-dimensional vision, and the vision should be in color. That is what I want you to create. Okay, so if you look at this and you look at all these things inside, these cavities inside or calcifications and various things, whatever else you see, really, when you're sitting in your clinic and you're seeing the CT scan, because we are surgeons and we operate in the chest and we have a good mental image of what tumors look like. So every time you look at the CT scan, every time you look at the chest x-ray, I want you to physically and mentally get an image of what is the tumor looking like in real life and what is going to be inside the tumor. So this image must form in your mind. Look at this multicavitatory areas. Look at this fat here. There are septae. There is some calcification here. Everything, all of this image should actually form from the CT scan. That is why the CT scan is your best friend. But you must learn to understand that the CT scan is a 2-dimensional representation of a 3-dimensional pathology. The patient is 3-dimensional. So always in your mind, you must try and work out what is it going to look like in real life. And if this picture doesn't come in your mind, then you have not become a good clinician. Okay. So please learn to make the picture in your mind. That is the only difference between you seeing the CT scan and me seeing the CT scan. Because when I am seeing the CT scan and when I'm seeing this CT scan compressing on this vascular structure, I am able to make an image in my mind where I can see the compression on the pulmonary artery or aorta or whatever it is. Okay, so I can clearly visualize this in my mind because I have a 3D training. I've trained my mind to think 3D, not 2D. Okay. All right, just 1 second. I'm going to log off this screen share because I don't like these lines in there. So let me stop the screen share and then restart because somebody has got that. Okay, so, okay, did this make sense what I just told you guys?
Yes.
Yes, sir.
Yeah.
Yes, sir.
So always make CT scans your friend. Listen, it's the same principle as when you are batting in cricket. Okay. If any of you have played cricket at a good level, you'll realize that initially the bat is a very heavy bat. When you go into the nets after a few months and you want to bat, the bat is very heavy. It really is difficult to lift the bat, and you think, how the hell can I hit a six with it? Sachin Tendulkar uses a very heavy bat. The reason why he uses a very heavy bat is because he can hit a six with it.
Momentum.
But for his height and for his weight of the bat, it is very heavy. But with practice, as you keep looking at things again and again and again, the bat suddenly becomes lighter. And that is the difference between experience and inexperience. The bat has to become lighter, and you stop thinking about the bat. At the moment, all of you guys who are struggling CT scans are thinking of the bat. You're thinking that this is a very difficult investigation. I'm not able to understand where is the brachiocephalic artery, where is the subclavian artery, things like that. After a little while, as you keep going again and again and again to the image, all of that will go in the background, and suddenly the bat will become lighter and hitting a six will become very easy. And this is the image that will come in your mind. So whenever we as seniors see this, we see a three-dimensional image. You see a two-dimensional image. And that is the difference. That is where experience comes in, because I have seen thousands and thousands more CTs than you have. So I can very easily use this thing to understand the three-dimensional. Okay. Now, Bhushan.
Yes, sir.
I want you to come in, okay?
Yeah.
Now, I'm going to give you a technique of how to learn to describe a CT. Okay. Now, Bhushan, what I want you to do, imagine that you are talking to a blind man. You are describing to a blind man. The audience is a blind man. And the blind man has never seen this structure. Okay?
Okay. Yeah.
So what you have to do is the next picture which I put up, you start describing the structure to give me, the blind man, an image of what is going on the screen. Is that okay?
Yes.
Did you understand what I said?
Yeah.
Okay.
Yes, sir.
I'm just going to put it up. All right. Don't give me the diagnosis.
No.
Give me a description.
It is an insect-like thing which has got this thing, butterfly-shaped wings with beautiful pattern over it, and it has got legs, small legs, and it is sitting on some fruit or something globular thing. The insect part is central part, and its wings have a specific pattern, which is trapezoidal in shape when combined together, and there are some veins branching over its wings, and having orange color and yellow color with black margins.
Anything about spots?
Yeah, there are white spots at the end of the wings. Continuously.
Anything
Green
about the
background.
object on which it is sitting?
Yeah, it is sitting on a some
Globular.
global or
Anuj,
some
1 minute.
rounded.
Anuj, switch off your phone.
Yes, sir. Sorry.
Some rounded fruit or something which has got small spikes or spicules on it.
Anything about the surrounding?
Yeah, the surrounding looks like it is in midst of a forest or some densely dense forest or somewhere where everywhere greenery is there and lot of plants are there.
Okay. So this is exactly what you're doing when you are describing a lesion on a chest X-ray or a CT scan. Do you understand? This is for everybody. This is all that you have to do. You have to describe whatever you are seeing right in front of you, including that structure in orange, including the pattern on that structure, including the shape of what those wings look like. You have to describe what is on those wings, the veins that he's spoken about. He's spoken about the color, what it looks like. He's spoken about the various spots that are present on the periphery with a nice dark black rim. He's spoken about this nodular thing on which it is sitting, which could be either a flower stamen, or it could be a fruit. It looks like it's got spicules on it. That fruit has got spicules on it. He talked about the head. He spoke about the legs. And more importantly, he spoke about the surrounding structures. Now, this description, you don't need an FRCS or a MS cardiothoracic surgery or an MCH cardiothoracic surgery to do this description. Did you understand this? Everybody, did you understand this?
Yes, sir.
Yes.
This is exactly what you're going to do from now onwards. Every time you describe a CT scan to me or to anybody for that matter, you are actually talking to a blind person who has never seen a butterfly. And the quality of your description defines the quality of the picture that is being formed in the blind person's brain. Do you understand? This is the key thing to understand. So once Bhushan has described this so beautifully, the blind man in his brain is forming a picture and he can say, this is a beautiful butterfly. Do you understand that? This is the philosophy of reading a CT scan. This is as simple as that. You don't need to be qualified. You don't need to have done a radiology degree to describe a CT scan. Is that okay? All right.
Yes.
Thanks, Bhushan. Well done.
Yes, thank you.
So let's go to the next one. Bhushan, I'm going to ask one by one, and either you can take all of it or somebody else wants to come in. You can take it. This is just revision. I'm not going to question you. You just tell me what is what, and then we'll just move on. Okay. I'm not going to question you. So just quickly, somebody else come in. Shilpa, come in.
Hello. Yes.
What's this?
So the right paratracheal stripe.
What's this?
Zygoesophage, in the center, the middle one. The second one is the zygoesophageal. Okay,
okay,
PA.
This one.
Yeah, a zygoesophageal recess, and this is the PA, and the fourth one is the descending, the continuation of the PA.
Okay.
Or the descending
What area
PA.
is this?
Right heart border made by right atrium, cardiophrenic angle, then the liver.
What is this?
Then liver.
What is this?
Then the breast shadow.
What is
aortic knuckle, aortic knuckle, AP window, then
Pulmonary.
PA, left-sided PA, and then we have the left atrial appendage, then the left heart border made by the LV, and diaphragm, then the gastric fundus, and gas in the bowel.
Splenic flexure.
And the costophrenic angle. Left cardiophrenic angle. Trachea. Carina. Right main bronchus. Left main bronchus.
Well done. Okay. So it's as simple as that. Okay. Now next, somebody come in. Abba, come in.
Sir.
What is the difference between the two, and what can you highlight on this?
So the left side one is a AP or a AP X-ray, and the right-sided one is a PA X-ray. That means that on the PA the plate is kept in front. The beam is passing from the back, the posterior side to the anterior side, and the plate is kept in front. The difference between the AP and the PA is that in the AP, the beam is about a meter away, and in the PA, it is 1.8 meters away. In the AP, the structures which are lying in the heart shadow would appear much larger and less well defined with more hazier margins. On the PA, the heart shadow would appear clearer with sharper margins. And in the
Ribs?
AP, the scapula would be more prominently visible since the plate is lying on the back of the patient. Usually, commonly the AP, yes, sir, the scapular border. Usually, the AP is either taken in an ICU setup where the patient might be either supine or sitting up, while a PA is usually taken in a clinical setup. So that's as much as I remember.
Ribs. Any difference in this height of the diaphragm?
Yes, so the diaphragm would appear to be more flattened in the AP picture as compared to the PA X-ray.
Okay, so this is always taken in deep inspiration, and you get more ribs seen here and much higher, more lucency of the lungs. That's why you can see the cardiophonic and claustrophonic angle very sharply. Well done. Okay, now I'm going to go through a normal CT scan, and I want you to spend some time on it, and we will try and identify some structures. Okay, I'm going to play it for 1 minute. Okay, this is a 1 minute film. Just watch it, watch carefully. I don't want you to, this is normal, okay? So don't worry about pathology, just watch normally and see what you see. Thank you, Bhushan, for this. And Nikhil. Okay. Come in, who's next? Fitoon, are you there?
Yeah, I'm here, sir.
Yeah, 1 minute. Muzaffar Ali, please switch off your phone, please. Muzaffar, please switch off your microphone. Fitoon, first question. What is this?
It's CT with IV contrast.
Okay.
CT scan of the chest
What
with IV
window are you
contrast.
watching? What
No, we are
window are
watching
you
the
watching?
mediastinal window.
Excellent. Okay. So not difficult. Very straightforward question, very straightforward answer. What phase of the dye do you think was captured?
It looks like arterial phase.
Okay, stay there, okay? Stay there.
Okay.
I'm going to run this again.
Okay. Oh, okay. More venous.
You want to change your answer, or you're happy with your
Yes.
answer?
No, it's more venous phase.
More venous phase. Fantastic.
Yes.
That's very good. Okay, so that's the way you look at it. Okay, that's how you identify, because whatever is highlighted more is the phase. It's as simple as that. Nothing complicated about it. So because this is a venous phase, I'm going to ask you some things to identify the venous structures. Okay.
Okay.
Again, I will go and I will pause and I will point out, and you have to tell me what it is.
Okay.
Only focus on the veins.
Yes.
Okay. Two things are highlighted in this picture. Agreed?
Yes,
one
sir.
is here, which is coming across, and one is here. Agreed?
Yes.
Okay. Now give me names for what is this and what is this.
Left brachiocephalic vein, and the other one is the right brachiocephalic vein.
Okay. Very good. Excellent. I'm going to ask you to continue.
Okay.
Pause. Sorry. Oh God, this went. Sorry, it went ahead. I want to pause it. Just one minute. We'll come back again.
Yes.
Okay, what is the structure that is highlighted?
That's the SVC.
Excellent. Good. Everybody happy with this? So far, so good?
Yes, sir.
Yes, sir.
Yes.
Continue looking at the SVC, okay? What's happening? Fitun, what's happening?
Yes, sir. Oh, okay. So now we are seeing the azygos joining into the SVC.
Very good. Excellent. Everybody happy with this?
Yes, sir.
Yes.
Yeah?
Yes, sir.
Happy?
Yes.
Very clear. Okay. Okay. Fitun, continue looking at the SVC.
Okay.
Where are you? Fitun, where are you?
Okay. So we're entering the right atrium now.
Excellent. Very good. Simple. Isn't it? Not difficult at all.
Yeah.
So can you identify that one structure, which is the right atrium? Excellent. Now we go back a little bit, and I want you to see the other structure that is coming into view.
Okay.
All right. And that is the, okay, I'll pause it. 1 minute. I'll pause it. 1 minute. Sorry. We just need to get to the correct structure. What is this coming into view below the SVC? Which has got,
That's the pulmonary trunk.
okay, what do you think is this one? And what do you think
So
is
that
this
will
one?
be,
This one. Okay.
yes. So on the
I'll
right
play it
side is
again.
the
I'll play it again and I'll pause. I have to come with the correct one. Okay. Just one.
Okay.
Identify. Oh, come on. Sorry. Sorry about that. It's going silly. Sorry about that, guys. 1 minute.
Take your time.
Where is it? Share. I'm still sharing, isn't it? No, the sharing got stopped. Where is share? Okay, share. This is your slide. That's the slide I want to come back in. I want to go back into slideshow. I'm going to pause at one point, and I want you to identify two structures for me. Three structures, actually.
Okay.
Identify three structures. I'll point out, okay? 1,
Okay.
2, and 3.
Okay. So one is the RPA, and
Yep.
2 is the main pulmonary artery, and
Okay.
3 will be the LPA.
Excellent. Difficult?
No.
Excellent. Well done. Now, we're going to go down,
Okay.
and I'm going to pause at one point. Okay, I'm paused here, okay?
Okay.
I want you to put an X through this structure,
Yes.
like this. Put an X. What do you think is above? What do you think is below? What do you think is to the right? And what do you think is to the left?
Okay.
Forget the
So,
structure in the midline. I'm not worried about that.
okay. So the one is which is below will be the left atrium.
I'll point and you tell me what it is, okay?
Yes, sir.
So what do you think?
Okay. Left atrium.
Okay, what do you think this is?
That will be the right atrium.
What do you think this is?
That will be the RV.
And what do you think this is?
This would be the LV.
Okay, what is the structure in between?
That will be the aorta.
Yeah, the aortic outlet. Okay.
Aortic outlet, yes.
The outlet. Very good. Easy? So far, so good?
Yes.
Okay, stay there, okay?
Yeah.
Stay with me, and I'm going to stop at a particular point. I want you to identify two structures for me.
Okay.
Okay. there is something happening here, and there was something happening here. I missed it. It's in the previous shot. But sometimes you get both in the same shot, okay? So you see one structure coming here and one structure coming here, both of them opening into this one. So what do you think is that?
So those are the pulmonary
So
veins.
this one is
opening.
which one?
That will
This
be the
structure
right.
which will be there, okay?
The right pulmonary vein.
And what do you think this is?
And the left one, on the left pulmonary vein.
Okay, excellent. Easy, not difficult?
Yes.
Okay, very good. Now let's go back, okay? Everybody okay with this understanding, or do you want me to speed up?
Yes, sir.
It's worth spending. I'll tell you, these few minutes that you spend on this will make your clinical practice for the rest of your life. I promise you this, okay? All right. Pitun, you want to stay on, or you want somebody else to take over?
As you like, sir.
Happy to take on? Okay. Happy to stay on, stay on. You're doing very well. Okay, now we are going to look at the artery. Okay, this is not the arterial phase, but we are still going to focus on the arteries.
Okay.
So stay there, and I will direct this. What is this structure?
So that's the aortic arch.
Aortic arch. Okay. How many branches come off the aortic arch?
5. So we have now we are not seeing anything now.
Yeah, but name the branches coming off the aortic arch.
Okay, so we'll have the right brachiocephalic, and then the left common carotid, left subclavian. So that will be 3, not 5.
That's 5.
Yes.
I was waiting for the 5.
Yes.
Okay. Which is the first branch of the aorta? Simple question.
Coronary.
From the aorta or the aortic arch?
First branch of the aorta?
Aorta will be the coronaries.
Good, thank you. Okay, let's go back a little bit. We are going now into the arterial supply, okay? Okay, I'm going to stop here, okay? I want you to identify 1, 2, and 3 for me.
Okay, so 1 is the right brachiocephalic artery, and then 2 is the left common carotid, and 3 will be the left subclavian artery.
Okay, well done. Simple? Okay.
Yes.
We're going to keep moving ahead. And what is happening here? What is happening here? What is the right brachiocephalic is doing something. What is it doing?
So the right brachiocephalic is dividing into the right common carotid and the right subclavian.
Excellent. Okay. Did you understand that? It's already given away the subclavian. And then as you go further, it will come back again. This is not an arterial phase. That is why you cannot see it very clearly. But if you look carefully, you can see that division coming through. Can you see that? The subclavian is coming off the right common carotid, off the right brachiocephalic.
Which is the more backward, right? The backward one will be the
backward. Yeah, it will go. But this is not a arterial phase, so you cannot comment on it. Okay.
Okay.
All right. If there is a lymph node here, Pitun,
okay.
If there's a rounded structure and if there's a lymph node, what will it be?
So that will be the prevascular, right?
No, prevascular is. What is this? What is this structure?
That's the trachea.
This structure. Yeah.
This
and
is
what
the
is
trachea.
a lymph node in this area?
Okay, so that will be 2R.
Yeah, paratracheal. Right paratracheal. Okay.
Right paratracheal. Yes.
It's right paratracheal. Very, very easy to understand. Okay.
Okay.
Now we will go down a little bit more. So everybody happy with the vascular anatomy?
Yes.
Yes, sir.
It's actually as simple as that.
Yes, sir.
I promise you, it's as simple as that. There is nothing complicated about the vascular anatomy. What is the structure behind it?
That's the esophagus.
Esophagus. Well done. Why do you call it esophagus?
Why you call it esophagus?
Why do you think it's esophagus? What are the features that are telling you that this is esophagus?
It's behind the trachea and it is in the front
so
of the spine.
Location is important.
Yes. And there is looks like muscular tube with an opening inside.
Excellent. Yeah. And with what inside?
There is air inside.
Air inside. That's right.
Not opening.
That's why it's called as the esophagus. Easy? Anything difficult about this so far? Okay. All right. Now, the next CT. Thank you, Pitun. You've done very well.
Thank you, sir.
What is
Okay.
this area called as? This area?
This is the aorta pulmonary window.
Okay, good. Aortopulmonary
Aorta pulmonary
window.
is okay.
Yeah. What is the lymph node station of this window?
It will be 4. No, not 4. 5.
Five. Okay,
Five,
aortopulmonary
yeah.
is 5 and
It's
6 is
5.
para-aortic. Okay,
Yes.
good. So easy enough. So far, so good.
Where you would see the para-aortic
one
if you're looking here?
here in front of this.
Okay.
Here or here. Okay, wherever those are all 6. Or at the arch, just in front of the arch is 6.
Again, it's
One more
para-aortic.
question. Okay, one more question. Okay.
Okay.
What is this?
It's the carina.
Good. And what station is there?
So
subcarina
will be 7.
Good. Easy?
Yes.
Not difficult? Okay. What will be the lymph node in this area?
So that will be hilar, right?
Number?
So hilar will be 10.
10. Good. So 10 and 10. Right. Okay.
Right
Is
and
it
left,
easy?
yes.
There's nothing difficult about looking at a CT scan as long as you're looking at it in a systematic way. So very easy to understand all the vascular anatomy, very easy to understand all the lymph nodes, and easy to understand the airways. Okay, nothing complicated about this CT scan. So far, so good. Everybody happy?
Yes.
Okay.
Yes, sir.
Now Adnan asked me a question yesterday to explain about the lung lobes. He wanted to know the lung lobes. Okay, Adnan, are you online? Adnan,
Yes, sir.
are you online? Okay, Adnan, now
Yes.
I will take you first look at this CT scan. Okay, just see it. Don't do anything more. For 1 minute, just see it, hoping that this is the correct CT scan. 1 minute, I don't know that. No, sorry, I'll use the next one. This one. Okay, Adnan.
Yes, sir.
Don't fiddle with the screen. Just watch it. Okay. All right. Everybody, just watch it. Happy? Adnan,
Yes,
happy?
sir. Yes,
Okay.
sir.
Now, Adnan, come in and tell me what is this structure.
This trachea.
Good. Well done. Okay. Now, everybody only look at the trachea. Don't look anywhere else. Okay. Only look at the trachea. Adnan, what is happening here?
This is carina and trachea is dividing into right and left main bronchus.
Okay. Happy with that? Easy
Yes.
enough? Okay. Now look at the right main bronchus. And Adnan, can you see something going off the right main bronchus? It's a bit early, but it is there very clearly. Can you see this? Yes,
Yes,
or no?
sir. Yes, sir.
What do you think that is? What is the first branch of the right main bronchus?
Sir, right upper and right.
Excellent. No. Just right upper. Don't go and.
Oh,
The first branch of the right main bronchus is right upper lobe. Agree?
yes, sir.
Happy or not happy?
Yes, sir. Happy.
So everything that is being distributed by this bronchus is the upper lobe. Okay?
Okay.
Are you with me?
Yes, sir. I am with
All right.
you.
Keep watching. Keep watching. After the right upper lobe bronchus has gone off, what is the bronchus called as?
The right lower.
No. There's another name.
Lobar bronchus.
No.
Intermediate.
Bronchus intermedius.
Yes.
Bronchus intermedius.
Bronchus intermedius. Okay. So after the right upper lobe bronchus has gone off, the middle hasn't gone off. The lower lobe hasn't gone off. You still got what is called as the bronchus intermedius. Okay. Adnan, are you okay?
Yes, sir.
Okay. Now watch it. Okay. Watch it carefully. What's happened there? Can you see something going off?
Yes, sir.
Okay, that is the middle lobe.
Okay.
I'll tell you why. Because in a bronchoscopy, you look from the head towards the bottom. In CT scan, you're looking from the bottom towards the head. So if you know your bronchoscopy, you will know that in a bronchus intermedius, in a bronchoscopy, at 3 o'clock is the middle lobe bronchus. Take it from me. I'm just telling you this. That at 3 o'clock is the middle lobe bronchus. So here it is at 9 o'clock. It's gone off diametrically opposite. So this is the middle lobe bronchus. Okay, Adnan? Are you with
Okay.
me?
Yes, sir.
Forget the o'clock. Okay, I'm sorry I said that. Forget the o'clock. Just the next branch after the right upper lobe bronchus that you see is bronchus intermedius. The bronchus intermedius divides into middle lobe bronchus, and everything that it is supplying is middle lobe. Can you see this?
Yes, sir.
Clear? Absolutely clear? And
Yes,
then
sir.
follow the rest of the bronchus. What do you think this is? This is the lower lobe bronchus with the apical segmental coming up and common basal coming up. So apical segmental going this way, so this will become apical segmental, and this is going here, so this will become common basal. Did you understand that? It's as easy as that. So you
Yes, sir.
cannot, now let me just play this through, and then I will restart. And again, keep looking on the right side. Okay, I'm going to go back. Keep looking at the right side and tell me, without looking at the bronchus, can you tell me where the upper lobe is, middle lobe is, or lower lobe is? Don't look at the bronchus, look at the lung only. Honestly, can you tell me which is the upper lobe, middle lobe, or lower lobe?
Yes, sir.
You can? I can't. So usually the point I'm trying to make is that if you look at the parenchyma of the lung, the
Okay.
fissures are never well defined. Okay, there are few patients whom the fissure is well defined, and you can make out what is upper, which is middle, which is lower. Most of the patients is almost impossible to know which is upper lobe, middle lobe, or lower lobe. Okay, so all you
Okay.
have to do is look at the trachea and follow the trachea. Okay, so I'm going to do the right side once again. Okay, Adnan, just follow it. In your own mind, you make your decisions and see what's happening. Okay, focus on the trachea, focus on the trachea, focus on the trachea. Did you see that upper lobe bronchus going off?
Yes, sir.
Yeah, so that's the upper lobe. So this is all upper lobe. Can you see this spread? All of this is upper lobe.
Okay, sir.
As you go ahead, next branch is coming off. That's middle lobe. So this is all middle lobe.
Okay.
Yeah, and
Yes,
then the
sir.
next one that's coming off is the lower lobe. So this is all lower lobe.
Okay. Sir.
Did you understand? That's the
Yes.
way you decide the tumor is in the upper lobe, middle lobe, or lower lobe. It's as simple as that. Okay. Are you
Okay,
happy
sir.
with that? Now we
Yes,
go
sir.
back to the left side. Adnan, focus on the left side. Focus on the left side. Only focus on the trachea. Sorry, focus on the trachea. What's happened, Adnan?
Yes, sir. It is dividing. Trachea is dividing
Yeah,
to right and left main
right and
bronchus.
left main. Okay, agreed?
Yes,
Now
sir.
focus on the left main bronchus. Don't look anywhere else. Just look in the left main bronchus. What has happened?
Sir, it is
You see
dividing
this
to
going
left.
here?
Yes, sir.
Yeah, left upper lobe. And if I go one section ahead, you will see the lower lobe. Can you see that? So this
Yes, sir.
is all upper lobe. Everything that you saw is upper lobe from the top to the bottom. The lower lobe is this side. All of this is the lower lobe. And actually, if you look at the vascular distribution, there is a definite change in the direction. This one is coming this way, that one is going that way. So somewhere here will be the fissure in this line. So this becomes the lower lobe, because here is the bronchus of the lower lobe, and that is all still upper lobe. This has become lingula because you can see that. And watch the lingula thing. Watch this, okay? And see how low it is going. Oh, shit. Come on. Sorry about that. Sorry. So this is still lingula. Can you see that? Can you
Yes,
see?
sir.
This is still lingula. This is lingula, part of the upper lobe. Very, very clear understanding. As long as you know where the bronchus is going, there is nobody can misguide you. Is this clear now?
Yes, sir, it's clear now.
Have you
Actually, the
understood very
lingula going
clearly?
down was
Yeah,
confusing.
the lingula is going downwards. So I'll go back again 1 second. Let me just come here. So this is the upper lobe coming off. Here you can, if you look carefully, you can see a fissure because the distribution is different. So this is the apical segment of the lower lobe that's coming into view. Just watch that carefully. This is lower lobe here. This is lower lobe. So this is all lower lobe. If you look carefully, you can see the fissure there. This is still the lingula of the upper lobe. So there is a overlapping there.
Okay.
See there? Can you see that? This is still lingula of the lower lobe. Can you see that? Just
Yeah, you
let
can
me
see the fissure.
back 1 second. You can see the fissure here. Can you see that?
Yes, yes.
Yeah. So upper
Yeah.
lobe, lower lobe, right upper lobe, right middle lobe, right lower lobe. This is the way to identify. You cannot identify it on the basis of where it is, because the lung changes. Okay, sometimes the upper lobe is bigger, the middle lobe is smaller, the apical segment of the lower lobe goes up. It's very difficult until and unless you look at the bronchial anatomy. You cannot decide which lobe of the lung is the tumor in. You understand that? So you have to 10 times go up and down and keep looking at the bronchial anatomy, and that will help you to identify where the lesion is. Happy with that? Everybody happy with that? Yes or no?
Yes, sir.
Yes.
Yes, sir.
Yeah,
Yes.
is it very clear now? This is the key thing, okay? All right. So let's now get into the pathology. Thank you, Adnan. Well done.
Thank you, sir.
Let's get into the pathology. Somebody else come up. Who wants to come up? Who? The Ramaswamy is in the room? Ramaswamy, are you in the room?
Hello.
Okay. Somebody else. Is Ramaswamy in the room or not?
Hello.
You don't want to take part? Okay. Next, who else is in the room? Somebody just say, I want to talk. We have to move fast, guys. Otherwise, we waste time.
Yes, sir.
Sir, Vishwarup here, sir. I can.
Vishwarup, come in. Okay, Vishwarup, come in. I am not quizzing you. This is not an exam. I'm just using you to describe what you're seeing. Okay, please do not misunderstand. I'm not here to quiz you. Okay, Vishwarup, come in. And
Yes, sir.
I'll just quickly tell you a little bit about lung cysts. There's unifocal pulmonary lung cysts, or there is multifocal pulmonary lung cysts. You got to be able to identify each one of it looks a bit different. So there's a whole list of diagnoses that comes with lung cysts. Vishwarup, come in the room and
Yes, sir.
tell me a description of what is happening.
Sir, there are multiple cysts in both the lungs, sir.
1 minute, Vishwarup, 1 minute. Can I stop you for a second? Is there
Yes, sir.
anything wrong with this picture? Not the pathology of the thing, but the picture itself. Is there something wrong in the picture? Is there something more you wanted before you started talking?
Sir, I cannot see the heart shadow, and I don't know. I mean, maybe.
Even before that, Vishwarup.
Can I see
Even
an X-ray
before
of?
that, Vishwarup.
Can I see an X-ray of the same pathology?
No, okay, that's acceptable. But this shot, what is wrong with this shot? Before you start reading this shot, what is it that you want to confirm?
Labeling.
Sir, there is no side mentioned, right?
Identifiers.
Identifiers. You have to look for identifiers.
Yeah.
Okay.
Okay. So in the exam, they will take away the identifiers, but you have to say, you know, in life, in real life, before you start looking at the pathology in front of you, always look for identifiers and look for side. Okay.
Yes,
Does that make sense what I just said?
yes.
Okay, good. So look for identifiers, look for the side. Okay. Again, now start describing this. Just it's a snapshot. Describe that butterfly and the pollen to me.
So this is a CT scan of the thorax showing both the lungs. It is in coronal plane, and it is showing that there are multiple cysts in both the right and the left lung.
Okay. Anything else you want to talk?
The vascular structures are delineated, so it is a contrast enhanced CT scan.
Yeah, good. What window?
Something in the mobile.
What window?
Sir, this is a lung window, sir.
Good. It's easy. It's lung window. We are trying to see lung window. Good. Okay. So just describe something to me. No? Just describe what you're seeing. I like that. Multiple cysts you said, which are present. What? Upper lobe,
Bilateral.
middle lobe, right, left, where?
So multiple lobes are present bilaterally. In the right side, it is present in the upper lobe, middle lobe, and the lower lobe. The left side also it is present in the upper lobe, but less in the lower lobe.
Okay, yeah, fine. I mean, that's all right. I will accept that. But actually, even the lower lobe is gone on the left side. So this is a multiple distributed pancystic appearance of the lung. Talk a little bit about the vascularity if you want. Anything specific about the vascularity? Anything more or less or anything? Any comments? Or you can say that I can't comment. It's okay.
So I can't make out the right pulmonary artery, the beginning of the right pulmonary artery very nicely.
Yeah, but look into the lung. I'm not talking about this. This you cannot see because the section is not going through. I'm talking about this. Anything? Is there more vascularity, less vascularity?
Sir, there is less vascularity, sir, because I cannot see the vascular structures all over. I mean, I cannot see the contrast.
So there is more central opacification of the vascularity, but periphery, I think the vascularity has gone down, right?
Yes, sir.
Happy with that? Okay, everybody happy with that? It's a very basic description, but it tells you, what do you think is the diagnosis here?
Multiple cystic lesion of
bronchiectasis.
Just wait. Let Biswaroop say.
Sir, there is destruction
Everybody
of
else, switch off your phone, please. Switch off the microphones, please. Yeah, what do you think it is? Just give me a couple of diagnoses. I don't mind.
Sir,
you don't have to be right, Biswaroop. You don't have to be right.
Sir, there is a honeycomb appearance of the lung. I mean,
lovely. I like that. I love the word honeycomb. You're right. Give me a couple of diagnoses on this.
It could be bilateral bronchiectasis of the lung, sir.
Bilateral bronchiectasis of the lung. Okay. Anything else? You know of any other congenital disease or particularly more common in women, which might give you this picture? Not very common, but you have to. Have you treated young women with pneumothorax? Have you operated on a young woman with pneumothorax? It's a straightforward question, not a trick question.
No, sir.
But have you seen anybody do it? A young woman with, you do bulectomy and pleurectomy, or you do calcium.
I have seen.
Why do you send the lung for histopathology?
To make out whether it is Ebola or whether it is something else, sir. I mean, whether there is a
sure. So what are you thinking of? This is not fair to you, Biswaroop. This is not a straightforward CT scan. Unfortunately, it's the first one which came up.
No, it's
but
fine,
but it's quite a good understanding. This is actually a condition called as.
Sir, to see whether it is maybe these are pneumatoceles or kind of any cavitary lung disease.
Okay, good. Yeah, I'm happy with that. I'm happy. It's actually. Look at the CT scan, everybody. Look at the CT scan, everybody. It's a honeycomb appearance, multiple cystic, present in all the lobes of the lung, bilaterally affecting both the lobes, with loss of vascularity in the periphery, congestion in the center. The first thing that's going through my mind is this a disease called as lymphangiomyomatosis?
Yes.
Also think about other diagnoses like bronchiectasis or congenital cystic malformations within the lung. But this X-ray, everybody look at it, it is actually the classic example of lymphangiomyomatosis. It's okay, Biswaroop, you don't have to make a diagnosis. You have to make multiple differential diagnoses. I'm very happy with what you told, okay? Excellent, very well done, Biswaroop. Next, who wants to come in? Lymphangiomyomatosis, okay? called as LAM, L-A-M. Okay. Sorry, this was the most difficult CT scan of the whole of the lot. Unfortunately, it came up as first one. Okay, but it's just so classical that you keep it in mind. I'm showing this for you to keep it in mind. Okay, next one. Okay. Next one. Who wants to come in next? Anybody can come in. Simran, you can come in. You're a pediatric cardiac surgeon.
Good evening, sir.
Simran, are you in?
Yeah.
Okay.
Yes, sir. Can you hear me, sir?
Pediatric cardiac surgeon. Okay.
Right.
This
So
is a
this
shot which I've thrown at you. What do you just describe it first?
right. So this is a CT scan, contrast enhanced CT scan. There are no discrepitory markers on the CT scan, but the scan shows there's a multi-lobulated separated lesion on the right side, causing mass effect and shift of the mediastinum to the left-hand side.
Excellent. Excellent. I'll show you another shot of this. Okay. Same CT scan. Keep talking.
So the CT scan is a transverse section at the level of the heart, showing the lesion located to the posterior aspect of the right lung, and it is again multilobulated with septations and strands present in the cavity, and causing mediastinal shift to the left-hand side.
The most important thing is it's causing mediastinal shift. That's what I want you to tell me. Okay. Any differential diagnosis?
Is there peripheral enhancement in this?
Yes, I agree with you. There is evidence of peripheral enhancement because lung has collapsed and consolidated in that area. It is consolidating, collapsing and consolidating the normal lung. I agree with you. There is enhancement, peripheral enhancement. Excellent. What do you think this is? Give me a few diagnoses.
So most diagnoses would be multilobulated abscess.
Okay.
It can be emphysema with the bullous lung disease.
Okay.
So can this be cystic fibrosis?
Probably not, because cystic fibrosis is more generalized. This is localized to a lobe. Can you see? If you look carefully, see there's a fissure here. Can you see this fissure?
Right. Yes, sir. Yes, sir.
And this lobe is completely normal.
Fair enough, sir. Yes, sir.
This lung is completely normal.
Yes, sir.
But it is localized for some reason to this lobe. You agree with me or no?
Yes, sir.
So what do you think? Think of some diagnosis. I'm happy with everything that you've said.
Aspiration pneumonia.
Yeah. Okay. Yeah. What else?
Sir, AV malformation.
What if I told you this is a 2-year-old child?
CCAM.
Diaphragmatic hernia? Congenital diaphragmatic.
Congenital adenoid malformation.
Not sure.
Yeah, CCAM.
CCAM. Yes, sir.
This feature is classical of
yes, sir,
CCAM because it is actually multiloculated, multicystic with peripheral enhancement, compressing the lobe. It is restricted to one lobe, not going into the other lobes. Other lobes are normal, and the hyperinflation is causing a mediastinal shift. The heart is shifted to the right. And if in a pediatric age group, I would think more of CCAM rather than a hernia. I agree with you. You could think of hernia if you saw more sections. But like I said, you have to give differential diagnosis. So I'm not disagreeing with any of the differential diagnosis that you gave. But what I want you to understand is how to describe these things. Okay. Right. So beautiful description. I really liked it. Is everybody okay with this? Did you understand?
Yes.
Yes. Is it making sense?
Yes. Destroyed left, right lock syndrome. Differential.
Yeah, Jibril, destroyed right lobe. Yeah, secondary to tuberculosis, possible. I'm okay with it. You have to give me differential diagnosis, and then you have to do further testing to decide what exactly this is. Okay. So I'm okay with it because you don't know the clinical history at this moment. So because you don't know the clinical history, in an exam, this is what happens. I put up only one shot of the CT scan, and you have to talk about it. Or if I've got a screen with me, I will take you through the top to the bottom. A top to the bottom is more easier to understand, but the one thing you must not do in the exam is keep fiddling with the mouse. Okay, don't keep going up, down, up, down, up, down. That really irritates the examiner. Look at it, let it go from top to the bottom, bottom to the top, and stop. Don't fiddle with the mouse. and then please stop at the most relevant shot of the pathology and start describing the pathology. Again, you are describing that butterfly to me. It could be a moth, it could be a dragonfly. The quality of the diagnosis will depend on how well you describe the insect to me. You understand that? That's the point I'm trying to make. That's why I threw the first film, for you to understand that what you're doing in a CT scan is just describing to a blind man what you're seeing on the screen. And there is no reason why you cannot describe. So please do not fear the radiology in the exam. All you have to do is just start describing A, B, C, D, E. I showed you what to say: size, shape, consistency, margin, etc. You may not say all of it, but some of it if you say, and if you come up with 2 or 3 sensible diagnoses, then I'm okay with that. If somebody tells me that this could be a lung cancer, I will not argue with you, because who knows, it could be a multicystic lung cancer, possible, but less likely. More likely to be CCAM in a 2-year-old child. I like the answer of hernia because you cannot see everything from top to bottom. But this looks as if it's more invading into the lung. It's part of the lung rather than part of a, you cannot see a sac. If it's a hernia, then you would actually see a sac surrounding it. So hernia is less likely, more likely a lung pathology. Okay, so CCAM. This is a CCAM. Happy with this?
Yes, sir.
Yes.
Okay,
Yes.
Vikas coming. Anybody can come in, whoever wants to, I don't mind.
Yes, sir.
Yeah, Vikas, come in.
Yes.
Shoot.
Yes, sir. This is the unidentified CT scan, non-contrast CT with lung windows. This CT is showing multiple cystic lesions in the right lung. These are distributed mostly in the posterior aspect of the lung.
Are they in a single lobe or more than one lobe?
I can see one fissure going there, and
okay.
Cysts are in
So
both above and below this, below the fissure cell.
Good.
So it is in both the lungs, both the lobes.
Okay. What is proximal? Any description you want to do of proximal something happening? What is this area? Can you see this?
There are
this is
multiple.
Okay.
Probably there is some lesion which is obstructing the airway.
Or is it peribronchial thickening?
It's peribronchial fibrosis.
Yeah.
Okay.
And
anything else you want to describe, Vikas?
Compensatory.
Volume loss.
One minute, Vikas. Everybody, wait, Vikas.
It's mediastinal shift.
Maybe. Yeah, there is mediastinal. Yes, there is mediastinal shift. And I think the vascularity of this particular lung is less on the periphery compared to the other side.
Is okay. Anything else?
No, sir.
That's it.
Sir,
anything else on the other side?
Compensatory hyper.
Hey, wait, yeah, please. We can't do it like this. We can't do it like this. Only one person answers, please, because we've got 100 people on the meeting. We cannot have everybody talking. Just one person answer. Vikas.
Yeah.
On the other side.
Yeah, other side. The left lung is hyperinflected.
Okay, that's good. And what else? Anything else you want to comment? What is this? Anything? Just say something about it, Jika. Just describe the butterfly to me. Atelectatic changes, fibrotic bands. Use any word. I don't mind what you want to describe. But this is not normal lung. You agree with me or no? This is normal lung, but this is not normal. So there is evidence of some atelectatic fibrotic changes in the other side as well. What is the diagnosis, Vikas? Give me more than one diagnosis, it's okay. Are you with me or no? Vikas seems to have gone. Shilpa, come in and give me a couple of diagnoses.
Hello. So,
what do you think?
It
Just
should
give me a
be
couple of diagnoses.
okay. Congenital cystic bronchiectasis involving the right lung, because
Why
there are
congenital?
multiple thin-walled cysts. So it should not be inflammatory or post-tubercular ones. Hence, we can say that it could be.
My suggestion to you, Shilpa, in an exam is don't overdiagnose and don't try to jump into the deep well. Okay. If somebody asks me what is the diagnosis, I would say more likely to be bronchiectasis. It's as simple as that.
Okay.
Yeah, I would just use the word bronchiectasis. I would not go into congenital bronchiectasis and things like that, because then you are, unless and until you know the features, that's different. But in a standard clinical examination, if I saw this, I would say this is more likely to be bronchiectasis. I'd like a good clinical history, and I would like to examine the patient before it does anything. I would also like to see the chest X-ray of this patient. Okay? Simple. Nothing complicated. This is cystic bronchiectasis, as simple as that. Okay? Make sense? Just stay simple.
Yes, sir.
I'm teaching you to stay simple. What happened because you went away?
I have some lousy internet connection, sir. Yes,
okay, all right. Don't worry about it. We'll accept that as your excuse. Okay. All right. Next one. Who's next? Come in quickly. I don't know who's there. Somebody just say yes. Nikhil, come in.
Yes, sir.
Just describe what you're seeing in front of you. By the way, just stop, Nikhil. Everybody, is it making sense?
Yes.
Or is it going too slow?
Yes, sir.
I'm very happy
sir.
to
Yes,
go
sir.
through all the
Yes, sir.
slides and describe everything myself, but that's not what this session
it's
is
perfect.
about. Okay?
This way.
Yes.
You're happy with that?
Yes.
Yes, sir.
Nikhil,
Yes, sir.
describe to me what you see.
So this is a this is a chest view, well centralized, and there is a hyperlucent shadow is seen in uh, right lung mid zone.
Okay.
It's well defined.
Yeah.
Irregular but well defined shadow.
Okay. Yeah.
Without any calcification.
Anything else? What about the rest of the lung? Talk about it. Talk about the cardiac. You've described this. Don't stop. If you're describing that butterfly to me, you have to talk about the background. You have to talk about the garden. You have to talk about the flower on which it is sitting. Okay, so talk about this also, no?
Yes, sir. So, trachea is in central position without any feeling defect.
No, all I would say is rest of the lung appears to be normal, because we are actually adults now.
Yes,
okay.
sir. The
rest of the lung appears to be normal, with cardiophrenic, costophrenic angles being normal. Okay.
Yes, sir.
And the cardiothoracic ratio appears to be normal. Okay. That's it. It's very simple. Give me some diagnosis on this, Nikhil.
Sir,
what is coming to your mind?
Cystic lesion or a
okay, good, very good. I'm very happy with that.
Malignancy.
No, give me some diagnosis for cystic lesions. No, first.
Sir, simple lung cyst, hydrated cyst.
Do you think this is hydrated cyst?
No.
No.
So don't talk about it. What are the simple lung cysts that you know of? Simple lung cyst. Come on, guys.
Lung abscess.
Lung abscess.
Okay, one lung abscess. What else? What are the common lung cysts that you know of? It's not a difficult question.
Bronchogenic.
Bronchogenic cyst. I'm happy with that. Anything else? Anything else? Is it close to the pericardium?
Pericardial cyst.
Pericardials.
Yeah, it could be. We don't know that. On a chest X-ray, we don't know that. What you need is, what is the next investigation you want, Nikhil?
I like to have a CT chest with contrast.
No, before that.
Old
before
chest
that.
Old chest X-ray.
Lateral.
Good. I want to see the old chest X-ray. And if I gave you one investigation to do, what is the next investigation you will do? Somebody just said it.
Lateral view X-ray, sir.
Lateral view. Thank you very much. So you will do a lateral view to see the relation of that cyst or it could be still malignancy. We don't know that. There is still a shadow there. The features don't look malignant because it looks pretty well-rounded, but it could be malignancy. We don't know that. Okay, so this is a normal, simple bronchogenic cyst. The reason why I think this is bronchogenic cyst is because of the cystic lucency and the presence medially. Most likely, bronchogenic cysts come in the midline towards the mediastinum. Okay, they can be peripheral as well, but more likely to be bronchogenic cyst or a pericardial cyst. That is what I'm thinking of. Okay. All right. Describe
So
this
can
one.
you say? Can you say?
Stay with me. Yeah, Vitun, what do you want to call it?
Sorry, could you say sequestration for that one, for the X-ray one?
Possible. Anything is possible on a chest X-ray. Very difficult to say that. But cyst is more common because the consistency was more cystic.
Okay.
Okay, Nikhil, stay with me and just describe this one to me. Same patient.
Yes, sir. This is the mediastinal window of the same patient with arterial phase contrast, showing well-defined cystic lesion in the right side of the chest, having smooth surface and isodense throughout, isodense and having the same consistency throughout the lesion, seems to be.
Okay.
Without any lymphadenopathy. Without any lymphadenopathy.
Talk. Lymphadenopathy, I wouldn't jump on at the moment because you're not talking malignancy. You're still talking lots of benign things. Talk about surrounding structures. No pressure effects. Is there any pressure effect?
It is slightly abutting on the carina, sir.
Yeah, so it is close to the right main bronchus. Okay. What else? Any other pressure effects? Or there are no pressure effects on what?
It is also abutting the SVC, sir. Slightly abutting the SVC.
That is right. So there are no pressure effects on the SVC. That's what I'm trying to tell you, that it's abutting the SVC, but doesn't seem to be compressing the SVC. It's lying very close to the right main bronchus. There is some irregularity of the margins if you look carefully here, but that could be also related to the compression that is causing on the lung. And more importantly, what is this? What is happening here? Can you see this?
Calcification.
Either calcification or increased contrast. Okay, so the contrast rim is being taken off. We don't know that at the moment. Calcification is usually more dense. Contrast is more likely. So there is some increased contrast take up at the rim of the cyst. Diagnosis quickly.
Bronchogenic cyst.
Yeah, good. I'm happy with that. Simple. It's very simple. Okay. My first diagnosis probably is a bronchogenic cyst. Any other cyst you want to call it?
Sir, since it cannot be differentiated from the pericardium very well, it could be a pericardial cyst.
We don't know that because we haven't seen the up and down images. Okay. So it could be more than one thing, but it's very easy to identify that this is a cystic lesion present in the right chest, the right main bronchus, with no evidence of obstructive pathology within the lung my first diagnosis probably is a bronchogenic cyst. Okay,
So
does it make
there are
sense?
few solid areas in the cystic.
Maybe you're right. Maybe you're right. If you look carefully, maybe you're right. But it's very
Mixed bag.
difficult to say this on a single shot. Okay, so you could say it. I will not challenge you. Okay. All right. Okay.
Can it
Next.
be esophageal duplication cyst?
Stop. It cannot be esophageal duplication cyst. Let me go back because it is esophagus is here. Look, here is the esophagus. Can you see that? Here, it's not there. But
Can we
if you
localize
want
it
to
to
call
upper
it, you
lobe?
can call it. But usually esophageal duplication system. We'll come to that. Just be patient. Next. Somebody describe this. Who is next on the room? Quickly. Let's move fast, guys. Cyst should finish fast.
Sir,
We have to
Arif,
get
sir,
to solid lesions.
I would like to
Arif,
describe it.
describe this quickly.
Sister,
Really
this is a
quickly. You have only 2 seconds to do it. Come on, quickly.
this is a chest X-ray. This is a CT scan mediastinal view showing uh, the bilaterally homogeneous bilaterally homogeneous lung fields with cardiac shadow. The There is a tumor just adjacent to, there is a homogeneous opacity just adjacent, anterior and adjacent to the cardiac shadow. It is single with single cystic solitary retrosternal just below the anterior right-sided cartilages, and it seems to be homogeneous. It seems to be abutting to the pericardium, and the bilateral lung fields are barrel shaped. So the patient might be emphysematous, but I need the mediastinal window to comment further about the lung fields. And
Arif, don't over-diagnose, don't over-talk. Okay, just
yes,
you
sir.
see something here. It's quite clear. You described it beautifully. The only thing that you didn't tell me is the relation to this.
Yes, sir. There is no. There is. It's adjacent to the anti-RV. RV shadow of the cardiac. It's
What is
abutting
outside the
the
RV?
pericardium. So it might be attached to the pericardium. There is no. There is.
Okay.
I
Good. I
can't
like
comment
that.
on it, sir. But there seems to be. It seems to be
Yeah.
coming from the pericardium.
Okay. Good. What do you think is the potential diagnosis? Give me a couple of
Potential.
diagnoses. 2 diagnoses.
Anterior mediastinal tumor. The diagnosis most commonly in this will be I will suspect pericardial cyst followed by a small thymoma, maybe a retrosternal thyroid that is present.
Very low.
Retrosternal thyroid, thymoma, lymphomas. It can be a teratoma also.
Don't get into that conversation. This is a cystic component. It could be a thymic cyst. I agree with you. It could be a bronchogenic cyst. Possibly it could be a pericardial cyst. Those are the only things that are coming to my mind. Okay. The margins are nice and smooth. I'm not thinking in terms of malignancy. This is just a simple pericardial cyst. Okay. The answer is obvious facing you in the exam. You try to make it more complicated by talking about things which are not there. So don't talk about emphysema and barrel shape and all that. This is what happens in an exam. Okay. This is just simple. I just put it up for you. All I want you to talk is describe the cyst to me, describe its relation to the structure surrounding it, and give me 1 or 2 diagnoses. That's it. Okay? That's what you do in life, isn't it?
Yes,
so don't
sir.
overdiagnose.
Sorry, sir.
Don't overdiagnose. Don't diagnose emphysema or barrel-shaped chest and all that. There is a pathology staring at you in the face. Just please describe the pathology. Is this clear? Also, now you can see what mistakes you make in an exam where you try to overdiagnose and tell me more things which are not important. I'm being your friend. I'm just putting up a very simple image in front of you. Just describe that image. Tell me 1 or 2 answers. That's it. Okay?
Yes, sir.
Is it
Sorry,
clear?
sir.
Okay. Don't over talk. Please don't over talk. Okay? Very important. Okay. Somebody tell me what is this? Quickly, somebody else. Come in quickly. I can't waste so much time. Quickly. Who's next? I can't. Bhushan, come in. You're my fallback guy.
This is a coronal view of MRI of chest.
I'm
It
so
is in a
happy you just picked up.
T2 weighted image with showing well-defined, enhanced, smooth margin, single cystic lesion in right paracardiac region, at the level of heart, the 4-chamber view of heart. Uh, so my differential diagnosis would be a thymic cyst, pericardial cyst, or a bronchogenic cyst.
Excellent. I'm very happy. Very well done. Important thing is it's in relation to the pericardium. Can you see that very clearly? It is actually in relation to the pericardium. See this pericardium coming here, and then there is a break here. So it is actually in relation to the pericardium. But I'm really happy with your description. Excellent description. Well done, Bhushan. Okay, this is a pericardial cyst, and I am very happy you picked up that this was not a CT but an MRI. So well done. Okay, somebody come in. Quickly, guys.
Can I come in again?
Fitun. Who is that? Fitun, come in.
Yes, sir. So it's mediastinal chest CT scan, mediastinal window. We don't have identification. So we can see homogeneous opacity at the posterior mediastinum behind the trachea with some compression on the trachea causing narrowing and slit, like the trachea shape has been changed to oval shape.
Excellent.
Hemithoraces, they don't seem equal on this view. So we see right hemithoraces as if more volume than the left hemithorax. We need to see other views to identify.
Give me differential diagnosis.
Okay, could be neuroendocrine tumor because it's in the posterior mediastinum.
Cystic.
Oh, yeah.
So first
Cystic
talk
lesions.
about cyst rather than tumors. So it is a cyst. You agree it's a cyst or no?
Yes, looks like
so
a
talk
cyst,
about
but
the
it's
cyst
homogeneous.
Yeah. What do you think? Give me one or two differential diagnoses quickly.
Cystic
I don't
lesions in the
argue with
posterior
you about
mediastinum.
neuroendocrine tumors and all that, but just what is the first diagnosis in that area?
Esophageal dilatations.
Yeah, esophageal duplication cyst, number one.
Yeah.
Number two.
Bronchogenic cyst.
Bronchogenic cyst. I'm happy with that. If you tell me this is,
here.
could be a bronchogenic cyst or could be an esophageal duplication cyst, I'm very happy. Okay.
Or esophageal dilatation.
Sorry,
Can
who
you
is
say
that?
esophageal dilatation? Is it acceptable? Just the
No, this is not
esophageal.
esophageal dilatation. This is not. There is a cystic lesion here. There is
Yes.
no. You cannot see the esophagus here. The esophagus is somewhere in there compressed. This is not esophageal dilatation. Because the thing that you see in esophageal dilatation is air.
Yes.
There is always air in an esophagus. Okay. Here, this is a cyst. This is not esophagus.
Yeah.
All right. So I do not
Bronchogenic
agree
can
if you tell
happen
me.
posterior mediastinum.
Yeah,
That's okay.
bronchogenic can be anywhere in the body. That's the problem. So bronchogenic, this can be. My first diagnosis would be esophageal duplication cyst. My second diagnosis would be bronchogenic cyst. Okay, as simple as that. That is how the exam is held. It is very simple. It is not complex. Don't over-diagnose things. This is beautiful, Fitun. Excellent explanation. Okay.
Thank you.
Somebody else come in quickly. Come on. Let's not waste time on cyst. Who's next? Who's there? Ramaswamy, are you there or not? Or you're not part of the discussion?
Sir.
Shashikaran coming. Okay.
Yes, sir.
Describe this to me.
This seems to be a non-contrast CT.
Good.
In the prevascular area, there is a solid lesion with the peripheral rim of calcification just in front of the arch of aorta.
Yeah, let me just stop you for a second. That calcification is a line which we have put. I'm sorry about that.
Okay.
It's I put it there, so sorry about that.
Scared actually.
It's not. It's not.
It's in the prevascular area.
But let me help you. Let me help you.
That
That is not there.
Homogeneously isodense kind of lesion.
What is it? Give me an answer.
Probably a thymic cyst.
I'm happy with that. Okay, I'm happy with that. That's simple. It could be thymic cyst. It's just quite so obvious in that area. Okay. All right. Somebody else now. Come in. Who is next? I don't know who else is there. I can't remember all the names, but somebody just quickly come in.
Anuj.
Anuj, come in. Anuj, come in.
Yes, sir.
Take this, please.
This looks like a chest X-ray PA view, sir, because cardiac shadows are well defined. And in the right lower zone, we can see a cystic cavitary lesion with air fluid level, and cystic cavity can be seen. Margins are well seen, and the base of the cavity there is a fluid, maybe a abscess.
Differential diagnosis.
And hydrated cyst.
Okay. So describe the
lung
hydrated cyst to
abscess.
me.
Yes.
Talk a little bit more about hydrated. There are a few features you can see here.
Yeah.
Yes, sir.
This is very classic. That's why I want you to describe a few features.
Water lily sign, sir. Water lily sign.
Okay. Good. What else? Hydrated cyst. Okay. So let's go through some features of the cell. What is this?
So air fluid level.
Air fluid level.
Yeah. And what is floating in the fluid?
But
Daughter cyst.
water cyst. Daughter cyst.
This is called as a water lily sign. Okay. Where there are daughter cysts floating into that thing. Here, what has happened is that cyst is potentially about to rupture. And this is the membrane, the germinating membrane that is collapsed out. Okay.
Yes,
so it's very easy. This is water lily sign. Okay. See some other things. Stay with me, Anuj.
Yes.
Just describe this to me. Describe the arrow that you can see.
This circular opacification.
Yeah. Good.
In the right lower zone.
Okay. Describe the arrow.
So Fisher fluid.
Meniscus sign.
Meniscus sign.
Okay, good. Good. Somebody said that. Who said that?
Crescent sign.
Good. Well done. So it's an air crescent sign.
Air crescent.
Crescent sign.
It's an air crescent within the hydrated. Okay. What else is an air crescent sign?
Aspergilloma.
Aspergilloma.
Okay. So it's very easy. Nothing difficult about these things. Do you agree or no?
Yes, sir.
Yes.
Okay. All right. So all you have to learn is to describe that butterfly, and then you will be okay. That's why I put up that first picture for you guys. Okay, come in. Who wants to come in next? Shilpa, come in. Tell me what's happening here.
This is a chest X-ray PA view with the right dome of the diaphragm is well placed. However, it appears there's an elevation of the left hemi diaphragm, probably with
Can you actually comment on the left diaphragm in this picture?
it is difficult. Actually, it is difficult to comment on the left diaphragm.
Why are you starting your description with the diaphragm? Talk about the obvious pathology in front of you.
There's a F. There is a well-defined, probably cystic lesion. Cystic lesion with an air fluid level on the left lower hemithorax with thick, probably thick wall, thick uniform wall.
Hey, somebody's phone is really ringing. Shilpa, just your phone on here.
Okay.
Don't put the microphone to your mouth. Just hold it a bit further away.
Okay.
Something. What do you see in this wall? Is there something different you see in this wall? Can you see multiple layers or something?
Multiple layering is there. And it is
Can you see that?
wall.
Can you appreciate? There is one layer, then there's another layer, then there's another layer.
Yes.
What is this sign called as?
Onion peel.
Looks like an onion peel, yeah?
Combo sign. Onion peel sign, yeah. Onion peel sign. Hydrasis.
Narendra, switch off your phone. Narendra, switch off your phone, please.
So we cannot comment on the diaphragm in this.
Can you comment on the diaphragm? I cannot. I don't know what the hell. Where is the diaphragm? Can you say where the diaphragm is?
No, can't.
I have no idea where the diaphragm is. Okay, so don't talk about those things. Talk about the one thing which is staring in your face is the cyst. Okay. If you start talking about the diaphragm as the first sentence that you say, then that's not good in the exam. All you want is, here is a cyst. Here there is some opacity seen within the cyst. There is evidence of multiple fields happening. We can't see the cardiophrenic or costophrenic angle. What do you think is happening in this cyst?
The cyst is probably impending rupture.
Impending rupture. That is what it is. Okay. For all the cardiac guys who are with us on this program, this is actually called as an onion peel or a combo sign, where you see multiple layers of cyst. And this is because that air is now escaping into the capsule of the cyst, and this is about to rupture. Okay,
Yeah.
that's what it is. Very simple. Let's carry on fast so that we don't waste too much time. Somebody take this quickly.
Yeah, I
Bhushan, take
know
this. Bhushan.
Yes, sir. This is a coronal view of CT scan with no markers, lung window, which is showing a cystic lesion with the thickened margins, well-defined margins, and some membrane-like thing is within this cyst. Other lung fields, there are some pneumonitic changes present. Uh,
Probable
that's all.
diagnosis.
Probable diagnosis is ruptured hydatid cyst.
No, say hydatid cyst. Don't say ruptured at the
Hydatid
moment.
cyst, yeah.
Just say hydatid
Yes.
cyst. Still cystic. It
Hydatid
could be ruptured, but call it cyst, hydatid cyst. That's it. Don't
hydatid
jump
cyst.
into that. Let the examiner. Okay, come on. Who's Nikhil? Come in and quickly tell me what you see. If I'm forgetting somebody, you must remind me. Okay, I can't see anybody's face. So, yeah, Nikhil, come in and tell me quickly. Just 2 lines.
This is the this is unidentified mediastinal window of a chest CT scan showing bilateral homogeneous well-defined cystic lesions.
Okay.
With
Differential diagnosis.
Bilateral bronchogenic cyst.
Okay. Not common, but okay. What else?
Bilateral hydatid cyst unlikely.
No.
Yeah.
Why
likely.
unlikely? It is possible. The thing, the one cyst that happens bilaterally is actually hydatid cyst. Okay.
Yeah.
So bronchogenic is not common bilaterally, whereas hydatid is common bilaterally. So you should talk about common things common. Okay. Though the features are not very classical of hydatid cyst because you have just seen one shot. You haven't seen the whole thing. But bilateral cyst, usually you should think about hydatid cyst. Okay.
Yes, sir.
All right. Simple. Well done. Okay. So just quickly, here is the thing about hydatid cyst, 2 or 3 signs, air crescent sign or meniscal sign, which we spoke about, combo sign or onion peel sign, water lily sign. Okay. And always consolidation adjacent to the cyst is due to ruptured cyst. Okay. So this is something that you have to worry about. Okay. Forget this. Okay. Next. 25-year-old guy comes in with history of high fevers, not settling down. IV antibiotics have been started. Somebody come in and read this for me. Chandan, come in.
Yes, sir. Sir, this is scan lung window.
Yeah.
Hello, can you hear me, sir?
Yes, we can.
Yeah. So this is lung window, CT scan chest lung window, showing left-sided cavitary lesion with this highly dense margin, irregular cavities, left side, and it's shifting mediastinal towards the right side. And according to the history, it is most probably lung abscess.
What have you forgotten to describe? There are 2 things you didn't tell me.
Air fluid.
Air fluid level.
What is this?
Yes, sir. There's a fluid level.
Okay. And what is this?
Onion peel.
Not onion peel. This is actually consolidation, collapse consolidation.
Yes, sir.
Surrounding this area. So more likely to be a lung abscess. Okay?
Yes.
This is a description. The other
sir.
thing which I would actually comment on this is that the quality of the lung doesn't look good. It seems to have some bronchiectatic or some changes happening in both the lungs.
Yes, sir.
Okay? All right. Well done. What do you want next investigation for this guy?
Bronchoscopy.
Fluid aspiration and no, investigation.
Do you want to spill the cyst? What do you want to do next investigation? Somebody just said it.
Bronchoscopy.
Bronchoscopy. Well done. You want to do a bronchoscopy? You want to do what in a bronchoscopy?
Bronchoalveolar lavage.
Bronchoalveolar
analysis.
And so this is the follow-up of that CT. And gradually you will see that the lesion is resolving with antibiotics. So this is a good way to know that this is a cyst which is responding to treatment. Okay? Not cyst, this is an abscess which is responding to treatment.
Yes.
Okay? Next, come in. Thank you, Chandan. Well done. Who is next?
Thanks,
Somebody come in quickly. Vivek Srihari. Vivek, hi kya? Bhushan, is Vivek there?
Mundale is there. Example.
Okay, Vivek Mundale.
Ramaswamy is there, sir.
Hello.
Ramaswamy.
I got
Sir,
100 people on this. Where is
Yeah,
Vivek?
so Ramaswamy, please take it.
Yeah, I'm here, sir. Sorry.
Yeah, Vivek, take it, please.
Yes, sir. Yes, sir. So this is a chest X-ray PA view, which is showing a cystic lesion in the middle zone of the right lung. And on close-up view, there is a air crescent which we can see in that cystic lesion. The rest of the lung appears to be the surrounding lung on the right side appears to be little hyperdense, could be surrounding consolidation. And on the closer view, there is a solid lesion which is seen to be inside within the cystic lesion.
Very good. Diagnosis?
This could be
Aspergilloma.
lung abscess or an aspergilloma, sir.
Aspergilloma first. I would also say this could be early idiopathic. We don't know that as yet. It's not very clear cut. But
Sir, could it be a
aspergilloma will be my
malignancy?
first sign.
No
Okay?
malignancy.
Okay, good. Lung abscess less likely, more likely to be an aspergilloma. Okay, well done. Continue, Vivek. Just describe this.
Yes. So this is a CT scan lung window in a transfer section, which is showing a small cystic lesion. Small lesion in the left lung, most probably upper lobe, and showing air crescent. So, and also there is a left-sided pleural effusion, which I can appreciate.
Very good.
You seem to forget this fellow all the time.
So the fungal ball, basically.
Yes, there is a ball seen within the cavity. That's why last CT or X-ray also I was pointing out. So you have to describe this fellow. No, this is quite important. It's the classical sign of aspergilloma. Agree?
Yes.
Okay. Thank you very much. Well done. Okay, and I like you picked up the pleural effusion because very often people only look at that cavity and they forget the pleural effusion. Okay. All right. Somebody else quickly come in. Who is there?
Sir,
Vikas is
Ramaswamy
there.
here.
Vikas, come in. Ramaswamy, take this.
Yeah.
Take it, Ramaswamy.
Sir, CT scan of the chest with no identifiers. We are looking at the lung window, and we have bilateral thick-walled cavity lesions with soft tissue lesions within the cavities, sir. Classical bilateral aspergillomas. With the surrounding lung, the cavity has consolidatory changes with some healed fibrotic lesions, sir. Fibrosis as well.
So what is your description leading to? You described it beautifully. What are you talking about?
Bilateral
aspergilloma.
In what?
Could be tuberculous cavity, which is secondary.
In
You
post-TB
described it
sequelae.
beautifully, Ramaswamy. So this could be bilateral aspergilloma and previously healed tuberculous cavity.
Yes.
Okay, that's what I want you to say.
Yes, sir.
You described it, but you have to come out with the diagnosis. Okay, good.
Thank you, sir.
Everybody okay with this? So far, so good?
Yes.
Is it making sense or is it getting too much?
No, it's okay.
Good, sir. It's good.
Come on, let's carry on. Who wants to come in next? I don't know who's here. Just whoever is ticket. Vikas, are you there?
Yes, sir. Yes, sir. I'm audible.
Vikas, come in. Describe this.
This is
I can't hear you, Vikas. Your voice is going. Andre, are you there? Andre?
Yes, sir, I'm here. Come in, sir.
Take this, Andre. Just tell me what it is.
Right, sir. This is a non-contrast CT, no identifiers, and on the right lung field shows circumscribed, well-demarcated, dense lesion, radiopaque lesion, and the surrounding lung parenchyma is normal, and there appears to be calcification within, and there is no mass effect associated with that.
Excellent.
And I'd like
What
to
do
see
you think
previous
it
lobes.
is?
If I could measure it, solitary pulmonary nodule.
Okay. What investigation? What do you want to do next?
Sir, if I can see the similar lesion in prior X-rays, it has calcification in more than 2 years, and it's less than.
Excellent. That is the answer. Well done. Excellent. You want to see the prior calcification in that, okay? And you want to know whether is this changed or not changed. But because there is calcification in the midline and it's very well circumscribed, is more likely to be a benign lesion.
Yeah.
And the common benign lesion is hamartoma. Okay. Excellent. I like the fact that you said you want to see the previous chest X-ray. Okay, well done. Because if your connection has improved, can you come in and tell me about this? Is Vivek Srihari on the line or not? Not on the line. Vivek wanted to talk.
Vivek is on YouTube.
Achha, he cannot come in. Okay, somebody else come in.
Why is there?
Sir?
Why is there? Danish is there.
Bhushan, come in. Tell me what it is.
Okay, this is a CT scan lung window showing an split irregular mass lesion with variable densities, probably in the left upper lobe, and it is abutting on the fissure. This thing surrounding lung parenchyma looks okay, except the spicules in the margins.
That is the
Probably
most important thing. Bhushan, I want you to talk about the spicules straight away, because that is the key thing for this. Talk about the spicules and see the fissure is getting pulled.
Fissure is tented.
This is the classical sign. Yeah, the fissure is tented. This is real classical. This is, you look at it and diagnosis, most likely to be
malignant nature of pathology.
Yeah, so it could be lung cancer, we don't know, but it is malignant. Okay, well done.
Yes.
Excellent. All right. Is Abba still with us?
Yes, sir.
Abba, take this one.
So it is a non-contrast CT scan showing a lesion, a spiculated lesion present in the left lung field, most probably a malignancy, sir.
Okay, so good. I'm happy with that. Quite straightforward, nothing more. Okay, is Simran with us?
Yes, sir.
Simran, take this, please.
So this is a CT scan of contrast enhanced CT scan showing the lung windows and the mediastinal window. There's a spiculated lesion in the upper lobe with the regions and uniformly dense, with the surrounding lung parenchyma.
Next, what you want?
So I'd like to see a previous CT scan of the same patient to compare it with the scan.
Change size. And, what you want to do?
So if
2 millimeters change size. What do you want to do next?
A biopsy of the lesion, sir.
PET scan.
We'll do a PET scan first, sir.
PET scan first. Okay. PET scan first, and then probably biopsy this lesion if it is change size. Okay. This is the
between the PET and biopsy. So PET will be the second choice of investigation.
No, if you do a biopsy and then do a PET, the PET will be completely distorted.
Right.
Inflammatory changes. So you should not do PET first. You should not do biopsy first. You should always do PET first, because otherwise you're going to ruin the PET. The PET will not give effective. Okay.
Right.
So always PET first before you do a biopsy. Also possible that in a PET you might find a lesion in the D12 vertebra, or you might find a lesion close to the surface of the liver, and you don't need to do a CT guided biopsy of the lung. You can just do a needle biopsy of the lesion in the vertebra and get the answer. Okay, so it's important to do PET first, not biopsy first. Okay, somebody else quickly take it. Because
so good evening.
Is back,
I'll try.
Vivek, come in.
I will try once more, sir.
Try once more, Vikas, and then Vivek takes the next one after that.
Yeah, thank you, sir.
This is non-contrast CT of chest unidentified patient. Lung window. It is showing a heterogeneous lesion, spiculated lesion in the right lung, close to the periphery. the nearby parenchyma is parenchyma. I can't comment. So it is a spiculated lesion, and I can see some area of heterogeneity also in the lesion. Most probably it's a malignant lesion.
Okay,
And
stop because 1 minute. I want you to focus on this. Okay, now come back again. See this? This is a solid component, right?
Yes, sir. And ground glass opacity is
What
there
is
nearby.
this? Yeah, so
Surrounded
this is
ground
ground
glass.
glass surrounding the solid component.
Yes, sir.
Okay, so this is not just. How do you measure this lesion from year to year?
We have to measure in 2 dimensions and take the.
Yeah, but you got to go to the periphery of the ground glass. Okay.
Yes, yes, sir.
You
Yes,
understand that? So this
yes,
is
sir.
specifically put. This is a part solid,
solid
part
lesion.
ground
Part solid,
glass
part
lesion.
ground glass.
It goes down the pathway of the part solid, part ground glass, and most likely to be malignancy. You have to do the malignancy assessment of this patient. Low risk, intermediate risk, high risk. Okay.
Yes,
And then
sir.
depending on which pathway of the solid pulmonary nodule, you have to decide how to
We have
go.
to-
Okay. All
Yes,
right.
sir.
So it is a part solid. Don't forget the ground glass opacity next to it. Come in, Vivek, Srihari, quickly.
Yes, sir.
Quickly,
Good
this
evening,
is
sir.
just, yeah, throw it at me.
So there is a hyper dense lesion in the right upper lobe, surrounded by normal lung tissue. Maybe a solitary pulmonary nodule.
What is the description? I want a description.
Sir, well circumscribed.
It's a pure ground glass opacity, sir.
Regular margins.
Hey, hang on, yeah, let him talk, please. Use the words which I want you to use.
Maybe a ground glass opacity, sir.
What maybe it is a ground glass opacity. This is quite classical ground glass opacity. Okay. In fact, it looks multilobulated. Can you see there's another lobule?
Yes, sir.
And there's another lobule. So it's probably a multilobulated ground. If somebody asked me to describe this, I would say this is a CT scan of the lung with evidence of a lesion in the right upper lobe. Looks multilobulated, looks ground glass. Rest of the lung appears to be normal. I would like to rule out malignancy in this patient. Okay, that's
Yes.
the answer I would say. Okay, well done. Very well done. Okay, come on, next. Somebody come in quickly. Simran, come in. Simran, did you answer? Come in, take this.
Yes, sir. So this is a
Your baby.
CT scan in a coronal section showing a multilobulated hyperdense lesion in the left lower.
1 minute, Simran, 1 minute. Stop. What CT scan is this?
Contrast and answer.
Okay. Anything more than that?
CT pulmonary angiography.
CT pulmonary angiogram.
No, it's an angiogram.
Yes. Right. So
it is an angiogram because all the vessels are very well highlighted. Can you see that? All the vessels are very well highlighted. This is actually just a simple CT. This is not a contrast enhanced CT. This is actually a CT pulmonary angiogram.
Right, sir.
Describe the lesion, please.
So showing a multilobulated, equally enhancing lesion in the left lower lobe.
Hyper-enhancing lesion.
Hyper-enhancing. So most probable diagnosis would be an AV malformation in this patient.
Okay, well done. Very well done. Okay, AVM. This is very classical. But you have to identify what is the CT. Okay? Well
Right,
done.
sir.
Very well done. What's the syndrome?
I wouldn't be knowing that, sir.
HT, sir.
HHT.
Yeah.
Huh?
HHT.
What's the name?
Hereditary hemorrhagic telangiectasia.
What is the other name for multiple? If he's got multiple telangiectasia on the skin.
Oslo-Weber-Rendu syndrome.
Oslo-Weber-Rendu syndrome.
Oslo-Weber-Rendu syndrome. Okay, good. What is this? Come on,
Ganesh.
somebody.
Ganesh, take it.
Ganesh, take it.
This is a CT transverse sections lesions both the lungs.
I can't hear you, Ganesh. Your connection is not good. I can't hear you. Amina, are you on the line? Are you with the group? Amina?
Yes, Prof, I am.
Okay, Amina, can you take this, please? I'm sorry,
Yes,
I forgot about you, but
No,
can you
no,
take
yes,
this,
yes, all
please?
right. Yes, Prof, this is a non-contrast enhanced CT scan of chest, and there are multiple small circumscribed nodules which are present in bilateral lung fields, and there are some evidence of fibrotic changes in both the lung parenchymal fields as well. And I can see multiple chambers of the heart in this view, and there are a couple of small lesions which are present in the peripheries, and there is one abutting the left pulmonary vein as well. So right pulmonary vein as well.
What else can you see in the heart?
I can see bilateral pulmonary veins entering into the LA, and there is a
device.
There is a device, yeah. In SVC, I can see
Valve.
some
Tissue
sorry,
valve.
I mean,
Tissue
I
valve.
don't mean to put you on the
Tissue
spot,
valve.
but this is what happens, that when you get so hooked onto these nodularities, they really glare at you, and you get so hooked on the pathology that you completely miss this. Okay, there's something happening in the heart. You described to me beautifully the heart and everything, but this is an obvious pathology. Something is not right, yeah? So you must say there is some opacity or density on the right side, okay? Whatever it is, I don't want you to diagnose it, but at least describe it to me, okay? What probable diagnosis?
Prof, it's a lung with multiple metastatic lesions, and something must be compressing SVC, and that's why we have put a stent in SVC.
Well, we don't know if it's a stent. Let's not go there because at the moment we don't know if it is stent or not. But yes, I agree with you that this is multiple metastases in the lung. Well done. Okay, excellent. Amina, stay with me and take this as well.
So, Prof, this is another CT scan of a chest, and that is showing a homogeneous small opacity with regular margins in the peripheral lung field on the right-hand side. And just let me have a closer look at that. And actually, the periphery is less dense on the lateral side as compared to the whole of it.
Very good, very good. Differential diagnosis?
Prof, it can be hematoma, it can be
calcification,
it can be a calcification, it can be a lung bronchogenic carcinoma.
Okay, what else? It's unlikely to be carcinoma because it's well-rounded. But you're right. We don't know at this stage. It could be carcinoma. I agree with you.
Can we say SPN, sir?
SPN.
Yeah, this is a SPN. I agree with you. It's a solitary pulmonary nodule. But what are the other diagnoses? What looks like this?
Can it be a carcinoid, peripheral carcinoid?
Possible. Very good. What else can it be?
Metastatic nodule.
Adenocarcinoma in situ.
Yeah, it could be a metastasis, guys. It's a nicely rounded, peripherally placed lesion. Don't forget, this might be metastasis. So I agree with all your diagnoses. The one thing you have forgotten is to say this could be a solitary metastasis in the lung. Okay? All right. Next. Is Adnan still with us?
Okay.
Is Adnan with us? Okay. Is Fitoon with us?
Yes, sir.
Take it.
Okay. So some chest X-ray film with mostly it's a PA view. You can see multiple rounded opacities all over both hemithoraces, and there is a device passing possibly through from the right on the right, passing to the superior vena cava to the right atrium. Look like going to the right subclavian vein. It's a portacath mostly.
Okay, excellent.
And,
so it's a chemoport. Yeah, very good.
Differential diagnosis looks like cannonballs.
Cannonball metastases, likely cancers which can cause this?
Likely cancer.
Say likely cancers. What are the different cancers?
Follicular carcinoma, thyroid.
Adenocarcinomas.
Adenocarcinomas.
Ovarian cancers, sir.
Ovarian cancers. Good.
Follicular carcinoma, thyroid, sir.
More common
Follicular
are breast
carcinoma,
cancers,
thyroid.
breast cancers to non.
Breast cancer. I want you to talk about breast
Breast
cancer.
cancers. Okay.
All right. Okay. Fantastic.
Okay.
Come on. Keep going. Next. Who's next? Nikhil, come in again.
Yes, sir.
Describe what is happening.
This is unidentified mediastinal CT scan of the chest mediastinal window showing multiple irregular opacity, isodense opacities seen in bilateral lung fields.
Potential diagnosis?
Multiple metastasis.
Happy with that. Okay, well done. Somebody else come in, take this. Vikas, Ganesh, is your line back? Ganesh, is your line back?
Yes, sir.
Yes, sir. Okay, Ganesh.
This is a PET CT. It is showing lesion left side the hemithorax near left bronchus.
Which bronchus?
The left main bronchus.
Upper lobe.
Okay. Actually, it's the upper lobe bronchus, but
Upper
yeah,
lobe.
you're right. But it's coming into the left main as well. Okay, what else? Quickly.
This is
There is a classical golden S sign.
which is showing
What else do you see, my friend?
Collapse consolidation of the.
There is collapse of the left upper lobe.
Hang on. Ganesh answer. Ganesh answer, please. Lymph node, what else do you see? Okay. Amina, come in and finish this for me, please. What else do you see?
Prof, this is a classical golden S sign. When there is a lesion which is abutting the left, any upper lobe bronchus, it leads to atelectasis and collapse of the upper lobe, and this is a classical golden S sign on CT scan.
Okay, what is potential diagnosis?
Prof, it can be a carcinoid because it looks quite a hot lesion.
Okay, what do you think? What do you want to tell me about the PET for this patient?
It's an avid FDG uptake.
One minute.
There is quite a high uptake of glucose in this lesion, but I cannot see any other lesion inside the mediastinum.
What do you want to tell me about the PET of this patient?
DOTA scan.
This is not an 18 FDG PET. This is actually a DOTA PET. Okay. DOTA, gadolinium specialized PET. DOTA, DOTA PET, which is specific for carcinoid. This is actually not 18 FDG PET. Okay. So when you talk about carcinoid, always try and say DOTA PET. That's the right answer.
Okay.
Of course, we don't know that. At the moment, we don't know that because this could be lung cancer. But if you think it's carcinoid, say it's probably a DOTA PET. Okay. Because the great uptake is always seen on DOTA, not on 18 FDG PET. Okay. And I like the collapse consolidation.
Otherwise, for a hot lesion, can we give a differential of carcinoid?
You can give a differential diagnosis.
Prof, just one question at this point. Only if you are talking about carcinoid, then we are supposed to mention that it is a DOTA PET, or the appearance of the PET can itself tell us that it is a DOTA PET or non-DOTA PET?
No. Because DOTA is just the molecule.
Okay.
It's just a different molecule. 18 FDG is the molecule used in a standard PET. In a DOTA PET, the molecule is different. And the moment you say carcinoid, try to correlate it with DOTA PET. Say that this is probably a DOTA PET. And that's a good answer to give. Okay.
What's the sign?
Golden S sign.
What is the sign?
Golden as if golden color, and S as alphabet S.
Okay.
Excuse me, sir.
1 minute. Who is asking this question?
Shashikiran, sir.
Shashikaran, yeah. Shashi, we have got a few things to get through. Can we hold on? Unless it's absolutely desperate. Otherwise, we are already 2 hours down the road.
Okay, I'll ask at the end, sir.
Yeah, ask at the end. Let's finish the master because it's important you see these images. These are all classical images. Everything if you see here, it will come in the exam. I promise you this, okay? So let's get on with it. Somebody take this quickly. Come on, guys. Somebody take it. Bhushan, come in and take it quickly.
Chest X-ray PA view.
Yeah.
Okay.
Who's that? Somebody said chest X-ray PA view. Who's that?
Srinivas, sir.
Yeah, Srinivas, take it.
Sir, chest X-ray PA view. The left lower zone opacity. The mediastinal and the pleural borders are merged, and diaphragm also is not seen.
Okay, good.
So most probably massive left-sided pleural effusion.
Oh, pleural effusion. Does this look like a pleural effusion to you?
No, actually,
what do you get in a pleural effusion?
The pleural margin the fluid will sweep
What
up
do you think is
on
more likely?
distal
I'm
margin.
not denying that there is effusion here. There may be effusion. I agree with you. But what is more likely? Can you see this? Can you see this? See this? See this? See this? See this? What is all this happening here?
There is.
Is that the collapsed lung?
Here?
Pneumothorax.
No, this is the lung. There's
The
bronchovascular markings
outermost
on the
portion
lung.
is the normal lung. In the more medial to that is hypogenic.
Yeah, what is it? Give me one something.
Maybe a pleural thickening or mass lesion over that.
It's a mass. It's a mass. Okay, there is a mass in there. I wanted to say there is probably a mass in there, some sort of tumor in there. It looks tumorous. It doesn't look pleural effusion because of the irregularity. Stay with me and give me the next one. Same patient, give me this. Okay.
Sir, CT scan chest contrast enhanced at the level of bronchial bifurcation. Sorry, at the level of pulmonary veins.
Arch of aorta, pulmonary artery.
Pulmonary artery. So a large left pleural and mediastinal mass, homogeneous, well margined, no irregularities.
Is it homogeneous or is there some changes within it?
Little bit of heterogeneity in between.
Changes.
Actually, it's multilobulated. Don't you think so? There are multiple lobules within there. If you look, stand back and look, you will see there's a different density here. There's a different density here. So it's more like a multilobulated mass. The word I would use is multilobulated. Okay, you can see there seems to be a capsule. Agreed?
Yes, a thick wall is there.
What about this? What's happening here?
It is invading the chest wall muscles.
Excellent. What's happening here?
It is I don't know. In this view, I cannot see the pulmonary artery on the left side. Whether it is complete.
This is the pulmonary artery actually. And what is happening here?
Abutting it.
Abutting the pulmonary artery.
Abutting and what else? What is loss? What is this? What is this called as?
Loss of fat plane.
Fat plane. There's loss of fat plane.
Loss of fat plane.
Yeah, there is a loss of fat plane here. You agree?
Yes, sir.
Everybody agrees or no? There's a loss of fat plane. See, this fat plane is seen here pretty nicely. Out here, there may be some loss of fat plane, I think. But here, definitely, there is evidence of fat plane. What is happening here?
The complete collapse of the left lung there. And there's a thick capsule, little bit of calcification in the chest.
Yeah, but more than that, it's a collapsed lung that is giving it the impression of a capsule. What's happening here?
Pleural effusion.
Excellent, excellent. So you agree that that picture which you told me was a pleural effusion is not correct because really there is very little pleural effusion in this patient. You understand? That's why I was sort of shocked when you said pleural effusion because this is all mass. It looks very lobulated. This doesn't look like there is effusion. But on a CT, it's quite clear that there's not much effusion. Differential diagnosis. Guys, differential diagnosis. Come on, continue, Srinivas.
Germ cell tumor.
Differential diagnosis.
It can
It
be
is an anti-mutation mass,
Okay.
so 4 Ts.
4 Ts, excellent. Who said that? Just continue.
It can be a teratoma, it can be a thymic mass, it can be a lymphoma, or it very unlikely to be a thyroid.
Okay. But what else can it be?
Germ cell tumor.
Germ cell tumor. Germ cell tumor.
Would I say teratoma first, or would I call it a germ cell tumor?
Germ cell tumor first.
So talk about germ cell tumor because of this invasion and this irregular margin and out here, loss of fat planes. Teratomas do not cause loss of fat planes. So if you call this teratoma, I will question you. If you call it as a malignant germ cell tumor, I would think more. I would be happier with you.
Then it is fine. Yes, sir.
Happy? Okay, well done. Now let's not go into germ cell tumors.
One minute, sir. 1 minute, sir. 1 minute, sir. I request everyone, once they have spoken, please switch off the mic because there is a lot of noise coming, sir.
Okay,
After we have spoken, we should switch off our mics. Yes, sir.
I completely agree with you. Thank you. And I'm going to continue. I know it's quite a long time, but I want to finish these images, okay?
Yes, sir.
And go on to a third session, please. Is everybody okay with that?
Yes.
Yes, sir.
Yes, sir.
If anybody is not okay, you can sign out and hopefully see it tomorrow, okay? All right, come on, next. Who's next? Amina, you're still there?
I am there, Prof.
Take it, please.
Prof, this is a contrast enhanced CT mediastinal window, and it is showing a diffuse, it's showing a circumscribed mass which looks more or less homogeneous in consistency, and that is abutting, it's in the interior mediastinum and is abutting the ascending aorta, encroaching on the ascending aorta, and to some extent the superior vena cava as well. There is some extension from the mass interiorly that is going into the interior chest wall and behind and just behind the sternum as well. And I can see laterally there is a little bit of rim of calcification on this mass as well. And yes, Prof, I've said that the extension into the chest wall and just
differential diagnosis.
Prof, a germ cell tumor. And it can be a thymoma.
Yeah, the first diagnosis would be a thymoma on this, because here is can you see the thymus here clearly?
Yes.
And actually you can see it arising from the thymus.
Yes.
It's quite clear actually. So before germ cell, I would say thymoma first. It's more likely to be a thymoma, but everything else is possible. I agree with all the other diagnoses. But because you can see the thymus here very clearly, and it is arising from the thymus, and this location is quite classical for a thymoma. Okay, so I'm happy with that. Well done. Shilpa, are you still there?
Yes, sir.
Shilpa, take this.
Yes, sir. This is a CT scan showing the mediastinal window. There are no identifiers. There is it's a non-contrast enhanced CT scan. On the left side, there is a ill-defined cystic lesion, which is abutting the pulmonary trunk, but the planes are preserved.
Is it a cystic mass? Let me ask you this question again.
No.
Is it a cystic mass?
No, it's not a cystic mass. It's a homogeneous mass with some multilobulated homogeneous mass.
It is heterogeneous.
It's heterogeneous.
Heterogeneous. Okay, yeah. Yes,
Homogeneous means everything is same. This is heterogeneous.
Right.
Yeah. What else can you see?
With some calcification internally, as well as at the margins, at the peripheral calcification.
Differential diagnosis.
germ cell tumor, probably teratoma or any mediastinal mass.
Possible. What else?
On the favor of teratoma.
What else?
Retrosternal goiter.
Good. I
Goiter
like
also.
that. Who said
Yes.
that? Nikhil, well done.
Yes, sir.
Don't forget about retrosternal goiter.
Retrosternal
So the
goiter.
4 T's.
Yes.
You have to tell me the 4 T's.
Yes.
Okay? So this
Lymphomas.
turned out to be retrosternal goiter. So I know this. So that's fine. But I'm happy with all the differential diagnosis that you've given. Okay. So don't forget the 4 T's.
Is
Okay?
the sternum normal?
It is normal. This is no.
It's very
It is
high.
normal. It's just the section
very-
which is at that. There's nothing wrong with the sternum. Okay, this is just at the neck, just lower down. Okay, so it's all right. Okay, quickly now. Come on, next to the Nikhil. You want to take this?
Yes, sir.
Bolo.
This is a chest X-ray, AP view, PA views.
Okay, now just give me the pathology. We have gone through all of that. Now pathology. Just stick to the pathology.
There is a hyperlucent, well-defined shot in the right upper chest.
Yeah. What else?
Uncoast.
And the trachea is created on the same side.
The trachea is pulled to this side. Yeah.
The same side.
What else? Is it invading the chest wall or no?
No, sir.
No, it's nicely lobulated. Good. I like that. Differential diagnosis. Nicely lobulated tumor, potentially not invading the chest wall, situated at the apex of the right lung.
Pancoast.
And pulling the trachea to the side. Is this coming from the lung? Is it coming from a chest wall or is it coming from the mediastinum?
Coming from the lung.
Mediastinum.
It's pulling, na? Nikhil, it's pulling. So it's coming more likely from the mediastinum. The spillover to this side is only incidental because of the location, but it's more likely coming from the mediastinum. You understand? This is how you analyze it. Okay, now let me quickly go into this and show me what this is. Describe this to me.
Neurogenic.
The same tumor. Describe
Posterior
it
mediastinum.
quickly.
This is
Only the mediastinum, only the tumor.
Well-defined circumscribed isodense tumor with
I'm putting the vertebra and
abutting the superior vena cava.
Okay, good.
And there is a device into the superior vena cava.
Maybe, yeah, you're right.
contrast.
You're right. There is a device actually in the SVC. Correct. Well done. Give me differential diagnosis quickly.
Neurogenic.
4 T's. Thymoma, teratoma, retrosternal.
Posterior mediastinum.
Posterior mediastinum.
Wait, guys, let him finish. You carry on, Nikhil. Quickly, you're right. Just keep on carrying on. What is the first one? It's in the posterior mediastinum. What's the first diagnosis comes into your mind?
Neurogenic.
Yeah, it can be neurogenic tumor. But this is not just posterior because it's coming all the way up here as well. So we don't know what it is. It could be neurogenic tumor. It could be a teratoma. It could be thymoma. This was actually a germ cell tumor. Okay, so don't get swayed away just by a posterior mediastinum. Don't call it neurogenic. It could be anything because this is coming all the way from the front to the back. Okay.
Sir, in this particular thing, can we tell from which place it is coming? Whether it is coming from posterior mediastinum? Okay.
Very difficult to say that. Unless you see all the images, it's very difficult to say. But looks like it's in the posterior mediastinum. Looks like it's posterior mediastinum, but you have to see all the images. Okay, all right, come on. Next, quickly, Vikas, take it. Because
this is a CT chest non-contrast CT showing yeah. Am I audible, sir?
Yeah,
Non-contrast CT showing a
Yes,
heterogeneous,
yes.
well-defined, heterogeneous, well-defined mass in the right upper zone with areas of calcification, and it is pushing the not pushing. It is that's it. Abutting the
Abutting.
abutting the vertebral column. So probably it is arising from the vertebral recess neurogenic tumor.
Okay, good. Schwannoma. Okay, this was a schwannoma. Okay, well done. What is the next investigation in this patient?
We'd like to do a PET scan first, sir.
MRI.
MRI of the
And an MRI.
MRI is what you want to do to see whether it's invading into the
MRI.
vertebral column or not.
Invading
Okay?
the neural sheet.
All right.
Yes, sir.
Well, good. So now what is this? Vikas, continue.
This is an MRI.
Yeah.
What is this?
Diagnosis.
I don't know how to describe
I got this, sir. I got this, sir.
Okay, who's that? Come in. Shilpa, come
Shilpa.
in.
So it's an MRI neck showing in the left thymic region. There is a very small
Thymic, no.
neck region.
Next to brachial
Like not a
plexus.
thymic nodule.
Next to brachial plexus.
It's not. This is we are talking. This is thoracic outlet.
MRI of the thoracic inlet.
This is thoracic outlet. Bhushan, take it.
This is a MRI
Okay.
T2 weighted image with a well-defined homogeneous, more likely density mass lesion located in the supraclavicular or thoracic inlet region. Suggestive more likely of because it is close proximity to brachial plexus. Brachial plexus.
Good. So
And
you really want to see the involvement of brachial plexus.
brachial plexus.
Diagnosis is a neurogenic tumor. Okay.
Neurogenic tumor.
Okay. I won't go through this now. Okay. Are we guys still okay, or are you tired?
No, sir. Fine, sir.
Carry on, man. It doesn't
Fine,
matter.
sir.
Okay, sir. It doesn't matter. Just pleural pathologies. Okay. Somebody asked me the other day a question. I don't know who asked me. How do you know whether it's pleural or whether it's pulmonary? Take a screenshot from here. The angle is the important thing. If it is an obtuse angle, or if it is an acute angle. If there's an acute angle, usually it's coming from the lung. If there's an obtuse angle, it's usually coming from the pleura. Okay. And this engulfs the pulmonary vasculature. This just pushes the pulmonary vasculature. Again, this is centered along the chest wall, centered in the lung. Well-defined margins. This will have ill-defined margins. Okay. So I'll show you the picture. It'll be easier to understand. Okay. Somebody take this quickly.
Prof, this is a radiograph of chest frontal projection. It is showing that there is a pleural cap on the left hemithorax indenting the parenchyma of the left lung. And the indentation is quite homogeneous. And the margins seem to be regular.
Talk about this one.
Sorry,
Talk about this
talk
one.
about. Oh,
Yeah,
talk
talk
about
this
this.
side.
Okay. This is a non-contrast enhanced CT chest, which is showing that there is a lesion which is abutting. There is with a clear regular margins, and it is abutting the chest wall, and it is homogeneous in consistency.
Split.
It is and it is subpleural. It looks like it is covered with the pleura, parietal pleura.
Okay. So what is this? Is it a pleural mass or is it a lung mass?
It's an extrapleural mass. It can be a hematoma.
Don't call it an extrapleural mass. Call it a pleural mass, because extrapleural mass goes into the pad, the extrapleural pad fat. Okay, this is not going into the extrapleural pad fat. This is still within the confines of the pleura.
Okay.
First diagnosis.
Metastasis?
Doesn't look
Localized diffusion.
Yeah, it's loculated.
Localized pleural abscess.
Localized.
actually an empyema. It's a collection of
Yeah.
with calcification. Okay, and there is no this thing. So this is
Split
actually
pleurosign.
empyema. This is called as a split pleurosign.
Splits.
Yeah, okay.
What's
So
what
it's
is
probably a
called?
loculated empyema rather than a tumor. Okay.
What
Now
do you
see the
call it, sir?
next one. All right, Amina, stay with me and take this one. Amina, take this. You with me, Amina? Are you gone?
Can you hear me, Prof?
Yeah, I can hear you now.
Okay, so Prof, this is non-contrast enhanced CT chest, which is showing that there is a mass which is abutting the chest wall, and it has got regular margins, but it has it's not homogeneous; it's inconsistency, and there is it's invading the chest wall.
There is evidence that this might be invading the chest
Just
wall.
one tumor.
But the important thing is that the margin, that the angle is acute.
Acute.
Can you see that? The angle is acute. Can you appreciate that? So moment you have acute angles and something pushing into the chest wall, you don't know. This is more likely to be coming from the lung rather than the chest wall. This is the point that I was trying to tell you about. Okay.
Okay. All right.
This is more likely to be a lung pathology invading into the chest wall rather than a pleural pathology pushing into the lung. Look back there and look here. Okay. So that's the difference between the two. So it looks like a pleural tumor, but it's not. It's actually a lung tumor, which is. So look at this angle. This is very important. This tells you, moment you have lung coming on this side and lung coming on this side, the angle becomes acute. And this angle tells you that this is actually coming from the lung rather than the pleural. Okay?
Can we tell that it is not coming from the rib?
Nicholas.
This is split
Sorry,
pleurosign.
what was that?
Split pleurosign.
This one. Take this one.
Complete describe.
Chal,
Can I
jaldi,
take
jaldi, I
the
have to finish. Come on, guys.
CT scan of the chest?
Yeah, take it, Ramaswamy.
Yeah, CT scan of the chest. Sir, I'm describing the CT scan.
Yeah, go ahead.
Yes. CT scan of the chest, mediastinal window with a loss of the volume of the right hemithorax with severe ripple. And there is a
Excellent. I like
loculated collection with peripheral calcification uniformly.
Excellent.
Most likely a chronic empyema with calcification, sir.
Rib crowding.
Very good. What about this? Collapse consolidation of
Yes,
lung. Did
the
you see
underlying
that?
lung, the underlying lung is collapsed.
Collapse and consolidation. Very good. So this is probably a calcified empyema. Excellent, Ramaswamy. I'm very happy with that description.
Thank you.
We did this. Okay. No, this is come here. Somebody take this.
Yeah, I'll take it.
Yeah, who's that? Fitun, come in.
Yes, sir. So we have CT chest non-enhancing, non-contrast enhancing. We can see the left hemithorax is completely occupied by a non-homogeneous opacity with multiple consistency. There is you can inside, most likely to be some sort of necrosis. We're pushing the mediastinum to the right side.
Very good.
And there is loss, contact abutting also the pericardium. And abutting the major valve vessels, also in contact with the descending aorta, and also to the chest wall. There might be some invasion also to the chest wall.
Diagnosis?
Possibly it's germ cell tumors or could be
something occupying the whole chest. What is more likely?
Pleuropulmonary blastoma kind of infection.
Yeah, very good. So it probably is a pleural tumor which is coming. Okay. Something that occupies the whole chest usually is a pleural malignancy. Most likely it could be an SFT undergoing a malignant change.
Yes.
Okay, because
most
there is
invasion
of the chest, invasion of the chest wall. It could be a solitary fibrous tumor which is growing into the whole thing. The lung you cannot see on this film at all. Okay, so it's probably a malignant solitary fibrous tumor. Okay, but any differential diagnosis is acceptable. I am happy if you say pleuropulmonary metastases, pleuropulmonary tumors, other things. I'm very happy. But
Even
most likely
malignant
it's a malignant
mesothelioma.
SFC. Okay, somebody take this quickly. Ramaswamy, come in, take this.
Yes, sir. It is a CT scan of the chest. Contrast, sir. We are looking into the mediastinal window. Here we are able to see the left. The parietal pleura on the left side is uniformly thickened and ragged, sir, and which is invading into. I mean, we are able to see.
It is showing the fissures is involved.
Yeah, the involvement of the fissures and extend.
Pericardium.
Yeah.
Keep talking, keep talking. You're doing very well.
Ream enhancement.
Yes, there is a enhancement of the pleura. The pleura is irregular, invading into the lung parenchyma, and the fissures are involved. Most likely, it is a mesothelioma, sir.
Excellent, well done. Excellent, very good description. Vivek Mundal, are you there? Vivek, are you still with us?
Yes, sir, I'm here.
Vivek, take this.
So this is a CT scan of chest, contrast enhanced in a mediastinal window. We are looking at multiple loculated cystic kind of fluid-filled lesions which are seen around the circumference of the pleura, around the circumference of the left chest, and the surrounding pleura appears to be enhancing at the parietal pleura appears to be enhancing, and the lung is compressed because of the fluids. Would be multiloculated pleural effusion.
Okay.
Correct.
Differential diagnosis?
Could be multiloculated
Forget
pleural
the arrows.
effusion.
Don't go with the arrows. Just first shot, if you see it, what will you say?
So multiloculated pleural effusion.
Excellent. Very good. I'm so happy you're given the correct. So don't go into mesothelioma domain straight away. Okay. So the first thing that you see on a CT, this is probably a multiloculated effusion. You don't know what is the cause of the multiloculated effusion. That will be decided. But I would in the exam say this is a multiloculated pleural effusion. It could be due to any reason. We have to actually define it on that pleural biopsy. So you've got to get in there and take multiple biopsies. It could be empyema. It still could be infection. We don't know that. So be careful about it. Don't jump into mesothelioma straight away. Okay. If they ask you, you push into it, then you say that. But otherwise, describe this as a multiloculated pleural effusion. Okay. All right. Quickly, next. What is this? Come in. Who is next? Bhushan, Shilpa, whoever.
Hello,
Abba is there.
sir.
Abba can take it.
So it's a non-contrast
Abba,
CT
take it.
scan
Abba,
of
take it. Yeah, good.
it's a non-contrast CT scan of the chest showing non-contrast showing a mass present in the left chest posteriorly, seems to be arising from the pleura, and solid heterogeneous and
what do you see within it?
so it's solid and calcified.
Use the word calcified. This is
calcified, right.
Yeah, this is a calcified. Okay, it's a pseudo tumor. Okay, well done. Very good. So I like the fact that you called it a pleural tumor, not a lung tumor. That is important to understand. Okay, so this is a calcified mass on the chest wall, which is called as a calcified pseudo tumor. Okay, somebody else come in quickly. Is Simran still with us?
Yes, sir. So this is a CT scan transfer section showing a mass in the left hemithorax, irregular, with the probable invasion into the chest wall. Seems heterogeneous opacity. Most probably a tumor arising from the pleural surface mesothelioma.
Or what else?
The bones are abnormal.
What else
can
could
it
be?
Can it be one of the chest wall tumors? How do we
what else can it
them,
be? The reason why I put this at this stage is you must think of
Okay, so
Something
can it be
coming
a,
from
it
outside
can be
the chest.
can it be a cold abscess of the rib?
Unlikely, because the ribs is not showing. What else will happen in the pleura?
The fracture there, sir.
Pathology.
There is a fracture there. The fracture and the presence of the nodule there tells you what? What is happening?
Hematoma.
It's a bone. It's a bone tumor.
No.
Pathological
What is
fracture,
it?
sir.
Could be a pathological fracture.
Yes.
What else? Give me a diagnosis, Simran. Give me a name. I agree with all the other diagnoses you said. 100%. The one thing you've missed, which I want you to say.
Rib abscess.
Metastases. I want you to say metastases. Okay.
Metastasis.
Don't forget metastases. This could be
Yes, sir.
metastatic from
Rib
outside the
metastasis.
chest.
Yes, sir.
You understand that? So the presence of a pathological fracture, presence of this, everything else is acceptable. Osteogenic sarcoma, this, that. But don't forget to say this could be pleural metastases. I'm specifically making a point here. Okay, so don't forget to say that this could be pleural metastasis. Stay with me, Simran. Take the next one.
Wow. So this is a transfer section CT scan showing a massive mass arising in the left hemithorax, arising from within the chest wall and invading into the pleural space and externally. Most probably,
Is it a pleural or is it a lung?
it's a plural mass
Good,
or something
very
coming
good.
from
All right.
outside and invading into the chest wall. So it is multiloculated with the heterogeneous opacification with the speckled areas of calcification.
Not multiloculated, but multilobulated.
Multilobulated. Okay, right.
Not loculated. Loculation is different. This is a lobulation.
Yes, sir. Lobulated.
Okay.
Right. And
I'm trying to help you by pointing out something.
and it's involving the bone, involving the ribs on the left side.
Actually, the ribs look normal. That's what I'm trying to show you. That there is no
But no, sir,
erosion of the rib.
two ribs.
Can you see that?
Yes,
it's
sir.
a nice and smooth. The rib is smooth. There is no evidence of erosion of the rib at the moment.
Right.
You understand that? So
Yes,
what
sir.
is this likely to be? Give me a differential diagnosis.
Dilated system.
If we compare from the right side, sir,
So
one rib is totally gone.
Can it be
Where
a
the
soft
arrow is
tissue
there.
sarcoma?
Okay, soft tissue sarcoma, I agree. What else?
Lipoma.
Because just hang on 1 minute. What else? I agree with you. Soft tissue sarcoma. What else?
Myoma.
So any soft tissue tumor. Okay, let's not go into the histology of it. So I agree with you. Soft tissue tumor. What else can it be?
Can it be a mesothelioma invading into the chest wall?
Possible.
No.
What else can it be?
Can be. Oh.
Metastatic nodule, sir.
Thank you.
Metastatic,
I'm just waiting
exactly.
for you to say that. Okay.
Metastasis.
So please, I
Right,
was
sir.
trying to make a point that don't talk about local pathologies. It
Most
could be a
common.
metastasis from anywhere.
Yes, sir.
This is less likely to be a primary lung because this is not. The ribs are not involved at all. Look at this. The ribs are very clear. If this was any local tumor, it would usually erode the ribs. This is more likely to be a hematogenous spread and it has grown very rapidly. It has not actually involved the ribs. So all other diagnoses were correct. I have no problem with the differential diagnosis you gave.
Right, sir.
Don't forget metastases. That's the point I'm trying to make. Okay? All right.
sir.
Thank you. A little bit about Askin's tumor. This is specific tumor of the pluripotent cells of the lining of the pleura. Go through the textbook and it'll tell you all about it. Let's carry on to the next one, okay? Quickly now, really quickly, okay? Now we don't have time. What is this? Vikas, take it.
Sternal tumor, sternal metastasis.
This non-contrast CT chest showing a section at the level of arch of aorta. There's a large homogeneous mass arising from the most probably from the sternum. It is almost reaching the arch of aorta and compressing the thymus around. So it is most probably a malignancy arising from the sternum. First differential will be a costochondral tumor. Second will be osteogenic sarcoma.
Okay,
And,
it's a sternal tumor. That's good enough. But I'm very happy because you gave me all those. But don't forget, this could be a metastasis.
Metastasis.
Don't forget to put a metastasis in your list of differential diagnosis. Okay, come on, next. Who's coming in next? Nikhil, come in.
Okay, yes, sir.
Spot diagnosis, Nikhil. Spot diagnosis. Now, don't spend time describing it. Just give me a spot diagnosis. Nikhil?
Pectus excavatum.
Yeah.
Well done. Thank you very much. Well done. Not excavatum,
Carinatum.
carinatum. Why did I say
That's what.
Pectus carinatum. Okay?
Carinatum.
Carinatum. Don't bloody mislead me. Carinatum is what I'm quoting. Okay. Now, Amina, this is your baby. You know this inside out.
Yes, Prof. This is pectus excavatum. This one.
Okay. So let Bhushan take the next one. What is this, Bhushan? What is this X-ray?
Oh, this is procedure. Nus rod within the chest done for pectus excavatum.
Nus
Correction.
rod is not the word we use. What is the word we use?
Bar.
Nus bar.
Procedure.
Okay. What is this on the side?
The studs.
They call
Fixation studs.
Yeah, fixators. Okay, so they are fixators. You can have one rod, more than one rod. It depends on how they do the thing. Okay, so this is correction of pectus excavatum. All right. Okay. Somebody explain to me this one. Amina, what is this? Just explain for everybody.
Prof, this is Hallow's index that we are trying to calculate. And, we are comparing the anteroposterior to the transfer diameter of the chest, and anything which is more than 2.75 is significant.
Okay, good. So this is Hallow's index. Okay, A over B. Yeah.
Yes.
And more than 2.75 is significant. Excellent. Come in next, Vikas or Andre. Come in. Is Andre still with us?
Yes, sir.
Take this, Andre.
Right, sir. This is a 3D reconstruction of the. This is a 3D reconstruction from the CT chest, and it shows a rib-based. It shows 10, 11, 12. From the 10th rib, a growth rising out and eroding the cortices.
9th rib.
9, 10, 11, 12. Yes, sorry. The 9th rib, the tumor arising out of the shaft and eroding the
What
cortex.
diagnosis?
Osteosarcoma of the rib.
No.
Dysplasia, sir.
Fibrous dysplasia.
See this? This is classical fibrous dysplasia of the rib. This is not a malignant condition. Okay. This is classic fibrous dysplasia. This appearance of all along the rib with an irregularity on the surface of a rib is not a malignancy. It is actually called as fibrous dysplasia of the rib. Okay. This is just for your knowledge. Just something extra to learn today. Okay. Somebody come in with this. Vikas, come in if you are there.
Sir,
Tumor
here.
Tumor
Come on
arises
quickly.
Tumor in the
from the second
Capillary
rib.
tumor, sir.
See,
Second rib.
no. This is tumor coming from a posterior aspect of the second rib, sir.
Differential diagnosis.
Posterior tumor. It is
osteoma.
osteosarcoma of the rib.
Osteoma.
Any of the bone tumors, okay? Right from chondroma all the way up to osteogenic sarcoma, okay? On a CT scan, you cannot clearly, on this reconstruction, you cannot clearly say what it is. This needs a biopsy and histological confirmation of the tumor, okay? All right, it was actually a chondroma. Still got time? Everybody's okay?
Yes,
sir.
Yes, sir.
All right, quickly, what is this?
Pacemaker. Cardiac pacemaker.
Yeah, what is this?
Elevated right hemidiaphragm.
Right.
The diaphragmatic pacing.
One person coming. One person coming. Ramaswamy coming.
Yeah. Sir, it is a chest X-ray PA view. We are able to see a herniation. I mean, there is a diaphragmatic hernia, sir, on the right hemidiaphragm. Yeah.
Okay.
With yes, gas shadows.
What is the differentiation? How will you differentiate this a hernia from a eventration?
You can see the level of the diaphragm clearly.
Yeah.
Yes.
Dynamic flow.
Yes.
Ramaswamy, how will you differentiate an eventration from a hernia? What's the next investigation you will do?
Fluoroscopy.
Lateral view.
Before fluoroscopy?
Ultrasound.
Yes.
Before
Lateral chest.
fluoroscopy? Come on, guys.
Lateral chest
X-ray.
Lateral chest
Okay,
X-ray.
you'll do a lateral chest X-ray because you want to see whether the two diaphragms are at the same level or what the hell is happening. Actually, this was an eventation, but you can call this hernia as well because you can actually see bowel loops within it. Okay,
Yeah.
so from you can get a medial side herniation and bowel loop. So I'm okay if you call this hernia. That's not a problem. But then you need to investigate it a bit more. You need to get a lateral chest X-ray done, and you need to do fluoroscopy. That's the main diagnostic test. And a fluoroscopy will tell you whether the diaphragm is affected or not affected. Okay, happy with that?
Yes, sir.
Right.
Thank you.
Yeah, come in, Ramaswamy. Stay with me and tell me what is this.
Sir, sagittal section of the CT scan chest, sagittal section, we are able to see a defect in the diaphragm with herniation of abdominal contents into the chest
Excellent.
through the
hiatus.
What is the location of the hernia?
Through the hiatus.
Esophageal.
Hiatus.
Paraesophageal, sir.
It's a paraesophageal.
Paraesophageal hernia.
Okay, well done. Well done. Happy with that. Okay.
Thank you.
Now, I don't have time to go into each details of these, but I want you to see the snapshot and understand how to diagnose these. Okay. Are you happy with this? Are you okay with the speed?
Yes,
Yes,
sir.
sir.
I
Yes.
mean, I can slow down, but then we'll be here all night. Okay. Next one. Kitun, take this.
Yes, sir. So the sagittal section of chest CT scan, we can see there is herniation of the abdominal contents into the mediastinum. So it's again it's a paraesophageal hernia.
Is it
No, it's not
eventration
eventration.
or is it a hernia?
No, it is hernia. It is not eventration.
It's not eventration because the diaphragm is down here.
Yes.
So it's a hiatus hernia.
Hiatus hernia, not paraesophageal. Hiatus,
Okay,
yes.
good. Well done. Okay. What is this? This is very difficult. I shouldn't ask you. This is Bosdalis hernia. It's at the back. What is this?
Okay.
Somebody take this. I'll go back to the previous one in a minute. Sophie, you want to take it, or Vivek, are you still there?
Yes, sir.
Morgagni.
Yeah, Morgagni, sir.
So it's a hernia in the front, and that is a hernia at the back. Okay, here is the hernia. Can you see this herniation?
Yes.
So herniation at the back is usually Morgagni.
Bogdalic.
Bosdalic. And hernia in the front is usually a Morgagni hernia. Okay? All right. Esophagus, quickly, we have done this. Now, this is not difficult. We've done all of this, so I just want to show you and just throw the diagnosis at me, okay? We've done this in the last lecture. So, is Pallavi not with us? I forgot. Is Pallavi with us or she's not with us?
Is not coming, I think.
She's not on here. Okay. So, is Amir there with us?
Yeah.
I'm going Amir. Isn't it?
Sorry?
Yes, Amir Mohammed can come in. Tell me, what is this, Amir? What study is this?
Esophageal and endoscopic ultrasound.
Okay, good. Do you want to tell me what are the various layers, or we know this? Just tell me the 4 layers, 1, 2, 3, and 4. Bus. Don't go into 9. Just tell me 4 layers you see on an EUS.
From outside in adventitia.
Yeah, outside in or inside out.
Adventitia, muscular layer, submucosa, and the mucosa.
Muscular layer, what is there in the esophagus?
Sir, can I?
No, let him finish. No, Amir is still there. Muscular layer, what is there? Just a single layer or 2 layers?
2 layers, outer circular, inner longitudinal.
Okay, somebody give me a diagnosis.
Corkscrew esophagus.
What is the pathology?
Diffuse esophageal spasm.
DS.
Thank you. Well done. Corkscrew esophagus, diffuse esophagus. Somebody else take this quickly.
Zenker's diverticulum.
Zenker.
Yeah.
Vivek, take it. Sri Hari Vivek, take it.
Sir, Zenker's diverticulum, sir.
Excellent. Through the gap is through what area?
Killian's triangle.
Killian's triangle.
Yeah, Killian's triangle, yes.
Between the
Killian's dice.
cricopharyngeus and the thoropharyngeus.
Excellent. Somebody tell me what this is.
Barium salt.
Zenker's diverticulum.
Zenker's diverticulum more likely to be a traction diverticulum rather than a Zenker's, because there is tuberculous change in the apex. And, not clearly seen, but it's a tuberculous change in the apex causing a diverticulum. It's actually a traction diverticulum, not a pulsion diverticulum. Zenker's is a pulsion diverticulum. Okay, next. Somebody else wants to come in some new
Rat tail sign.
Not rat tail sign.
Adnan still with us?
Bird's beak.
Bird's beak.
Yeah, bird beak sign.
Somebody else take it. Chandan, you want to take it?
Yeah, yes, sir. This is a X-ray, chest X-ray showing
it's not chest X-ray.
barium the barium cello film, sir, showing bird beak appearance, the esophagus.
Diagnose?
Acalsia.
Excellent. Good. You've done this. Okay. What is this?
Apple.
Lower.
Yeah, I won't bother you. This is the diaphragm. It's very close to the diaphragm. It's an epiphrenic diverticulum.
Epiphrenic.
Forget this. What is this?
C esophagus lower one. Sure.
Ring the margin.
Again, not fair for you. This is not fair. This is not for you. It's intramural epidural. Forget that one, okay? That's not for you. What is this?
Sir, Scadscase ring. Scadscase ring.
Well done.
Esophageal ring.
Thank you, sir.
All right, guys. We have been through everything that is needed in histopathology, in radiology. Okay. I can't teach you anymore.
Wow, thank you very much, boss. Much appreciated.
Thank you.
Just one
Thank you,
minute.
sir.
Thank you, sir.
Thank you so much, sir.
Thank you, sir.
Excellent.
Let me just stop. I'm very sorry. It's been a very, very long lecture. I apologize.
Oh, come on.
Thank you, sir.
I will show you everything. Okay?
Yes, sir. Yes, sir.
It's important to see everything so that this is how the exam goes. You really know the diagnosis, you know the answer. Just learn to describe it. Just remember that picture of the flower. You have of the butterfly. You have to describe that butterfly to a butterfly. That's all you have to do. Okay. All right. I won't take any more questions now because I am tired and
yes, sir. Yes, sir.
Time. So let me just
butterfly was superb.
Thank
you, sir. Thank you, sir. Good night, sir.
Thank you, sir.
Right, sir. Thank you, sir.
Night, sir. Thank you very much.
Good night, sir.
Good night, sir. Thank you, sir.
Thank you, sir.
We had Dr. Faizul Islam with us again. Oh my God.
Yes.
I'm very sorry. It was a very long lecture, but it's very important to learn about everything.
Disciples, they're so attentive disciples,
No, it's
all the
good.
best wishes.
I'm very happy. And, more than 50 people stayed till the very end. So I'm very impressed with the audience. Well done.
No,
So,
Prof, I must say we are a bunch of very lucky people.
Yeah.
Yes, definitely we are.
The most lucky is I am.
of Corona, that's the important thing.
The most lucky is I am.
Corona,
Yes, nobody is as lucky as you, Nikhil.
The Corona means crown.
In school.
Ali Zamir Khan is at the crown as a teacher.
All right.
All
Okay,
the
so I
best.
tried to cover everything in thoracic surgery. One thing I didn't cover is actually pericardium and heart. If you want, sometime we can do a small talk on pericardium and heart radiology. If you guys wanted, we can cover that. That's not a problem.
Yes, sir. Yes, sir.
Yes, sir.
But it was becoming so much that I had to sort of cut short somewhere. Otherwise, it would be too long. So, okay, well done, everybody. And thank you for staying till the end. Anybody's got any pressing comments to make? Anybody wants any questions to ask? You know, my iPod finished the battery. We must be going
Our
for
phone has
leaving.
lost the battery.
Prof, I think we must leave everything, all the questions till the next session. Because
Thank you very much.
Yes,
Amina.
yes.
that
I'm so happy you're my friend,
honestly,
Amina.
Sir,
we
sir,
can
one
sit here
thing.
for another 2 hours. It's not
Thank
up
you
to
very
us,
much.
but honestly, you need some rest because you have been
Oh, my
talking
pleasure.
constantly.
Yeah.
Rest, and it's time for Maghrib prayer, so I've got to go.
Yes.
Yeah.